A very warm welcome to all our esteemed speakers from Tata Memorial Center, India, Merck Foundation alumni who are joining us online, and distinguished members from oncology societies and healthcare professionals joining us online for the 13th edition of Merck Foundation Asia Africa Luminary for the Oncology Session.
Thank you very much. On behalf of Tata Memorial Center, I would like to welcome everyone who's present on this webinar, and welcome to the 13th edition of the Merck Foundation Africa Asia Luminary Conference and to the Oncology Scientific Session that we are having today. It's a pleasure to partner with Merck Foundation for this educational program that we've been running for the last 10 years. And today, we've tried to have a mix of topics that would interest individuals and people working with cancer in various disciplines, including pathology, radiology, radiation oncology, medical oncology, and surgery. And we've also kept a talk on palliative care. So we've tried to include as wide a spectrum as possible. And I'm sure with the faculty that we have kept for you, who are all world-renowned personalities working in their own subjects, it's going to be a very, very fruitful session. And we would request all of you to post in your questions and queries to the speakers. And with that, I would wish you all the best and hope we have a great session. Thank you very much and welcome to all of you once again. The first speaker would be Dr. Tanuja Sheikh.
Hi, good afternoon, everybody. So today I've been told to speak about essentials of pathology and oncology. So I have to condense my 30 years of experience into a 20-minute talk. So it's going to be very difficult, but I'm a talkative person. So this is a difficult job. So they say that as is your pathology, so is your oncology. And I think pathology forms the center stage for for very good oncology practice. Today, we are in an era of personalized cancer therapy, and pathologist helps you choose to a large extent markers that will so the right drug for the right patient. That is what today pathologists help you do. So our day begins with a diagnosis, reporting of excite specimens like minimum data sets, predictive IHCs, prognosis, and molecular diagnostics. So our hands are full these days because we are become an integral part of oncology. So in the Department of Pathology, Tata Memorial Hospitals, we under the pathology, we have all these services, that is surgical pathology, molecular, cytopathology, and immunohistochemistry. Diagnosis is it's something that we pleasurably do because we have been trained to do it. And we have what we call as immunohistochemistry and over 200 antibodies to diagnose and predict cancer. Now, besides the diagnostic part, we play a very critical role in staging and grading cancers. The grade decides the treatment in many cancers like prostate cancers. After surgical resection, I think grossing and minimum data reporting, that's one of the critical aspects of pathology. And this dictates the clinical treatment pathway. We are in the world of theranostic and predictive biomarker prediction, and a lot of our work like MSI PDL1 is regularly done on that. So what is the flow for when people who are away from the pathology department will understand that whatever is operated upon, all those specimens come to us. It goes through a rigorous technique of processing, fixation, tissue processing, and we make it into blocks like these. These blocks are then cut for H&E slice, based on which we make diagnosis. Then we run some immunohistochemistry test and we decide what the tumor is. We put some predictive markers so that the clinician can guide the therapy. And besides this, we also have a digital pathology segment where we do remote reporting in some cases. So that's the nutshell. To give an example of breast, I specialize in breast and lymphoma pathology. So this is a breast specimen. So when it comes to us, we gross it in a very specific manner. We give a diagnosis, we give the essentials in the report that make the surgeon or the medical oncologist understand how aggressive this cancer is. We do biomarkers like ERPR, HER2, and that is essentially taking care of 95% of the breast cancers today. In oral cancer, just to give you a pattern of growth, like worst pattern of growth is very important in deciding therapy. And this tells you whether it's a circumscribed tumor or with a highly infiltrating tumor. We are in the era of theranostics where the diagnostics guides therapy because, and this is basically done on immunohistochemistry, we use regularly BRPR HER2 regularly. We also are doing a lot of markers on brain tumors and on lung cancers because these directly impact therapy. Now, one of the markers that has really taken off in the last couple of years is the microsatellite instability testing by use of MMR IHC. And we understand that Lynch syndrome patients can be picked up, and sensitivity to immune therapy is also one of the commonest indicators. This is a patient to show you the loss of these proteins on IHC that helps. And this is a test that has 100% sensitivity, and it is as good as high-end molecular diagnostic. In fact, NGS is lower down on the list than IHC, is that important a marker. PDL1 by IHC, that's the only gold standard. There is no molecular test for PDL1, and that's what we do essentially in a large part of our cancers. And we have other markers like MET, BRAF, etc. that we are now doing because there are targeted drugs available against that. We do this all in a synoptic reporting format. So we devised our own system. Dr. Swapnil, our colleague, has devised this format where we have, since 2018, we are entering all our reports. This is like a minimum data set for cancers are also entering. So we just have to tick, 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 and the report is generated. This ensures that no patient has any missing data and the treatment is complete. We also upload the molecular, the IHC. We can track the sample. So it's like a laboratory information system for us as well. Now, if you're doing pathology, you must practice good pathology practice. We must monitor the transport of specimen. We have to pay attention to the reagents we are using. We have to audit our tests. We have to train our histotechnologies. And we are the most important proponent of EQUAS program from Tata Memorial Hospital. So our experience of ERPR has been that after investing in quality improvement matters, today our ERPR has reached the Western status. And you can see that most of our patients have the ERPR HER2 data very similar to the patients from Western countries, which was not so the case in the year 2000 when our first data of ERPR HER2 was Pradeep. So essentially, it meant that quality is important in oncopathology. And without that, all your reports don't carry weightage. We run the National Cancer Grid EQUAS program from surgical pathology. We have now 398 centers registered with us. We run this to understand what is the diagnostic capabilities of these centers. We also send tissues to the centers to see what is the quality of the tissues coming out of the centers. We run our IHC program through these centers, and there's a huge demand for this EQUAS across the country because this is the only minimally charged EQUAS running in the country. Now, this is a paper which we published. Our first 5 years running this EQUAS, we found that centers who started the EQUAS with us today had much more automations in place and their performances were excellent. And this is a way, it's when we started the EQUAS, only 6 centers in the country had automated IHC. But as we improved on the EQUAS, 60 centers have automated IHC. So that just tells you that EQUAS helps you put the infrastructure in place, especially in low LMIC country. A molecular team led by Dr. Omshri Shetty is running the molecular EQUAS, and these are the tests which are offered. I'm sorry, some of the diagrams are getting hidden, but we offer all kinds of test menu that is there in molecular diagnostics, and they are part of the International Quality Network as well. We have got our NABL accreditation for the first. We are the first EQUAS for molecular diagnostic accredited in the country. We are offering this to 55 centers, and 3 neighboring countries are also part of this EQUAS. So I've been told to speak quietly. Quiet is not me. Sorry. So the Department of Pathology has also now gone into expansion of its digital pathology services. Mainly, we started during COVID era where we reported from home. We integrated various biomarker algorithms so that we had accurate biomarker reporting. This also eliminated physical handling of slides. We could do multidisciplinary tumor boards using this digital pathology slides. We are an educational and research institute, and these slides, therefore, digital archives provided us a huge facility to discuss slides with the students and trainees. And most importantly, Tata Hospital does not have space. So this helped us in storing our slides and avoiding the physical storage of slides. So we have 5 scanners, and you can see that we have the Roche system, the Philips system, Grundium, as well as the 3D Hystic digital scanner. This is a paper which my colleague Dr. Sangeeta Desai published during COVID epidemic, where we found that remote reporting was as good as reporting on glass slides, but this was only for specialties that are simple. So I am a lymphoma pathologist. I did not report lymphomas on that time in the pandemic on in the digital platform. We've also started doing frozens on a remote reporting, and you can see here that we had almost 7-8 cases only out of some 500 cases that were discordant, and that's because the quality of the sections was not good. So digital pathology is also good for remote reporting of frozen section, and I think this offers a tremendous opportunity for expansion of centers with high specialization like ourselves to the neighboring centers. We are using various computational pathology tools, and one of the tools that we have used, because I'm a breast pathologist, I'm part of the team that evaluated the ER, PR, HER2, and Ki67 in breast cancer using this VideoFarm AS tool. This is our results which have been published, and you can see that our concordance was as high as 95%. So essentially, what it told us that pathologists will agree on a test more commonly if they're using the same digital algorithm. And this simplified in complex cases, this helped us come to a consensus. This is just to show you some examples. So this is an ER state. Now we had called it negative, but the digital picked up these few nuclei which are positive in the tumor very easily. And that's why we could send a positive report. The same thing with this case. Now, in the HER2 algorithm also, what happens is, as pathologists, not many people have, with the smaller volume centers, don't know what to interpret as positive. So algorithms like this help you to train your pathologist better. So I always used to report equivocal little less. When I started using the algorithm, I understood what equivocal really meant, and that improved my own skill as a pathologist. So these are some of the examples from the same study. Now, one of the challenges of introducing molecular tests in any LMIC country is that molecular labs are not available anywhere. So this has been always my dream to introduce a bright field in situ hybridization for breast cancer, which is the D-dish for breast cancer. I saw it in the US 2016 in Europe, and I thought, no, we must get it in TMH. We did try it in 2017, but that was not a very huge success. But in the recent eras, we have implemented it on a routine basis. This is our first publication. We came out way back in 2022 that said that we had very good concordance between D-dish and FISH. So that improved our time. Earlier, FISH used to take 1 week. Now in 3 days, our D-dish reports go. And we have a fantastic agreement of 97% with the fluorescent in situ hybridization. So as long as you have the Ventana platform, you can run an in situ hybridization in-house. And I think this has taken off in the country very easily, because the way it is that there are not many molecular labs which are doing pathology, which have pathologists, and that's why pathologists are doing at least the D-dish is something that they can do. And this is our data about the reliability of this test. Now, because we were doing D-dish, we also used the AI algorithm for D-dish estimation, and this is a software which the Roche itself has, and we trained the software to pick up, and what it does is, see, the red tells you that this is amplified. If you see any orange areas, that tells you that. So it helps us reduce our time in counting the nuclei when you're seeing the case. And this was a fantastic software in a difficult case, because sometimes pathologists tend to miss those areas which are amplified. This is a publication from that, which said that there was a decrease in the turnaround time for evaluating the HER2 FISH slides. And that's the reason we have implemented it in routine practice. I think we are the first center in India to implement this. Several of my colleagues and me are working on AI prediction and prognostic based on a simple HNE. So imagine if I can tell you, based on a simple HNE, that this patient requires chemotherapy or not, something that an Oncotype DX, which costs 3.5 lakh rupees in India, if I can tell you based on a HNE, so this is the IBRI score, which we have, which Dr. Anand Madabuchi from Emory has invented, and which gives you the same kind of information as a very expensive molecular test. We are running several grants along with his team in head and neck, prostate, and breast cancer. Some of my colleagues are working on early detection of nodal metastasis using these algorithms. We have a huge biobank and computational pathology center, which is run by Dr. Swapnil Rani, my colleague at ACTREC, and all our images that are sent into the digital pathology center are stored there for use by anybody across the country. Now, clinical decision tree in cancer today is like this, that what we do routinely in pathology takes care of 85% of the cases. The clinicians does not have to spend a penny more. But for 15% of the cases, what happens is that there is need for something more, and we don't know whether these patients require chemotherapy, this requires targeted therapy, and that is where molecular diagnosis comes in. This is a game changer in oncology. Earlier, we just did tissue diagnosis and IHC. Today, we now use molecular tests on tissue samples, blood samples, to decide the genomics, to decide the proteomics, to tell us, is there anything differently we can do for this particular patient? And I think in 20% of cancers, this has been game changing. And the poster child is, of course, lung cancer. So these are the different avenues: FISH, PCR, Sanger sequencing, NGS targeted, NGS comprehensive, whole genome sequencing. We can go the whole way. It depends on your clinical need, what the cancer is, and this is evolving very rapidly in all cancers. Today, NGS has become very simplified, and we can use it regularly. So we have NGS start of 4 days in many of the situations by using a smaller targeted panel, and this is something that we're using regularly in our patients. So what to choose? It depends on your economics of the institute, whether what is the stage of cancer the patient is in. If the patient is in the early stage, you're not bothered of doing a high-end transcriptomics. You just want the baseline data that will help you with the targeted therapy. And what your medical oncologist is ready to give the patient, that also decides the therapy. Now, as I said, in lung cancer, NGS and molecular has changed the field of vision. A patient who would come in stage 4 lung cancer was to think that he will live 2 years. Today, he is living 5 years easily if he has one of these targets like EGFR, MET, ALK, ROS. And there are many more targets that are coming, like NRG1, HER2, MET, RET, everything is coming in. So the prognosis of lung cancer advanced stage is to be so abysmal. Today, we know that we are in a game-changing molecular diagnostic for lung cancer. And this is where all cancers are going. You can see it's a very complex diagram, but you have new mutations, especially the FGR-based therapies that are just picking up at a very rapid pace, not only across lung cancer, but also across ovary, prostate, and all cancer. And one of the most important cancers I think is being targeted is pancreatobiliary, because till today, we haven't been able to take care of the prognosis in that cancer. So this is where the precision oncology is evolving very rapidly. And you have to have your molecular team ready to get into it. And the pathologist is at the center of all this. So you have many ways to go about it. So you have many patients. You have to choose the right patient, use the right genomic X-ray test, use the right kind of a treatment, and then follow up with liquid biopsy or anything that you feel is right for the patient when it relapses, recurs, or whatever. So that center stage is the pathology. And I think that is why I'm sitting here and as a first lecture on this starting. So one important thing is that only a pathologist can interpret genomics. He or she can look at gene expression, proteomic data, and integrate it with tumor morphology. Sometimes there is discordance. If you don't involve your pathologist, you won't be able to pick it up. They can provide you with a comprehensive assessment of companion diagnostics and other biomarkers per patient, per clone, per cell basis. If you don't talk to your pathologist enough, then your oncology work is lacking in some way. As I said, we can comment on the presence, absence, differential expression of biomarkers, and tumor heterogeneity is something that is very much in our pockets. And it's interesting to know that 2 studies, the Neo-XL and the Foxtrox, they failed because there was too much pathology involved and there weren't many pathologists to deal with it. So that's so much important pathology is. So to conclude, I think you have to have good pathology as a cornerstone if you're going to do good oncology practice. Tremendous advances have occurred in the last few years in immunohistochemistry, molecular, digital pathology, and they have brought clinics to the pathology department. And now we are a very important part of the decision process maker. And I think if you want to do good oncology practice, you have to invest in good pathology practice for terminal cancer care. Thank you so much.
Our next speaker for the session is Honorable Professor Dr. Prabhat Bhargava.
So my job today is to cover metastatic breast cancer and especially in resource stratified settings. I'm Dr. Prabhat Bhargav. I'm medical oncologist and professor and consultant at Tata Memorial Hospital. So there is huge disparity between the medical advances available and what we are able to use in our developing countries, including India. And there is huge disparity between mortality data. If you see, more amount of mortality is there in the developing countries compared to what it is in the developed countries, especially for younger patients. Because in developing countries, more number of patients are in the younger age, and they suffer more. And because of the population pyramid, there are more patients in the younger age group, and hence there are more incidents of cancer in developing countries. And in developing countries, the dilemma is that there is fixed cancer budget, and I can either treat 10 patients with older age with less expensive regimen, or only 2 patients with high efficacy regimen using the same budget. So how can we resource optimize this is the task given to me today. So first thing we have to keep in mind is what is basic. At least core resources absolutely necessary for any system should be available, and single clinical interaction, and focus on simple, highly efficacious chemotherapies. So in breast cancer, it is mostly chemotherapy, but in metastatic hormone positive breast cancer, it is hormonal therapy. Then limited tier 2, where in resource tier, where you can add major improvement in survival, such things should be added and attend with modest infrastructure and limited financial means. So we even have to see whether we have infrastructure that if we give an advanced therapy, will it increase the side effect, and will we have more number of patient visit coming back to our hospital, and that will use more of our infrastructure, and thereby limit the use of infrastructure for the next patient who would not even start therapy because we are busy with the patients we are already treating. And there is enhanced option available, optional but important for important resources, and this increases quality of life in patient, but should be used very selectively. So just for my presentation today is for hormone positive breast cancer, the basic that a patient should get is some form of, in hormone positive breast cancer, is some form of hormone therapy and best supportive care together. In limited resources, if possible, they can at least undergo bilateral oophorectomy and non-steroidal AI if possible. Or enhanced would be as first line therapy with a non-steroidal AI with CDK4/6 inhibitor. For an HER2 positive disease, a basic therapy would be to give some form of chemotherapy, preferably anthracycline. But if patient is able to afford trastuzumab, that does not increase load on the infrastructure because it has very limited side effects added to the background of chemotherapy. But yes, financial implications are there of adding trastuzumab. So if a trastuzumab is being planned, then the chemotherapy background preferably would be paclitaxel. And enhanced would be if biosimilar pertuzumab is available, as it is available in Indian scenario, then trastuzumab pertuzumab combination on the backbone of a paclitaxel or taxane-based regimen. In triple negative breast cancer, single agent chemotherapy is the basic that all patients should receive. In limited resources setting, yes, single agent chemotherapy, and in unsetting only, it should be added to the PDL1 inhibitors, immune checkpoint inhibitors like nivolumab or pembrolizumab. So navigating from hormone positive breast cancer, clinical is whether patient is premenopausal or postmenopausal. If patient is premenopausal, then tamoxifen should be given. And if possible, easily possible, then ovarian ablation should be added, either surgical or radiotherapy based. And when patient is postmenopausal, at least AI should be given. And if there is enhanced all resources available, then such patient should be AI plus CDK4/6 inhibitor. Based on the multiple studies that we are aware of CDK4/6 inhibitor, where patients were randomized to AI alone or fulvestrant alone, compared to addition of one of the CDK4/6 inhibitor like ribociclib in Mona Lisa set of trials, abemaciclib in Monarch set of trials, and palbociclib in Palma set of trials. What they showed that giving hormone therapy alone versus given dual hormone therapy and CDK4/6 inhibitor, it increases the time to progression. That patient will progress later, and roughly there is doubling of the time for progression, whether you use it in first line or second line. But only ribociclib has shown overall survival benefit. The time to overall survival, total lifespan of patient is increased by only ribociclib. So, and while adding such therapies, you need to keep in mind the class effect of all CDK4/6 inhibitor, like diarrhea. So, patient have to visit frequently to your OPD and use your and resources. So, adding one CDK4/6 inhibitor may increase intent will increase one back for a side effect, and you may not be able to treat one more patient later on, a new patient. So, should we really add CDK4/6 inhibitor compared to the side effects that I have displayed on screen, like hepatotoxicities with abemaciclib and ribociclib, QT prolongation with ribociclib, and neutropenia leads, especially with palbociclib, and that lead on paper neutropenia. There is no neutropenia, but till patient recovers from neutropenia, even your speed goes high fast, and you will have to call that patient again until neutropenia recover. So can we take CD4 inhibitor rather than giving it first line therapy for a research constrained setting? So this study is Sonia study. Patients of metastatic cancer treatment naive were randomized to first line AI or AI plus CDK4/6 inhibitor. And on progression, those patients who were on CDK4/6 while patients who were on AI were given CDK4/6 inhibitor on second line. So is CDK4/6 inhibitor must first line itself was the question that they asked. And will the total duration of PFS1 and PFS2 be equivalent to CDK4/6 inhibitor in first line? They found that PFS1, the progression-free survival in first line therapy with was roughly 16 months, as we saw in previous CDK4/6 inhibitor trials, and the progression-free survival at CDK4/6 was 24. In equal survival of all patients, whether you give them CDK4/6 inhibitor in first line or second line, the line was 24. Whereas if you have given them in second line, the duration of exposure was only 8 months. So the number of adverse events were 1,400 if you give it in first line, compared to 200 second line. So the frequency of OA is reduced and the resource utilization is reduced. And cost of therapy, obviously, your patient have to pay for CDK4/6 inhibitor. If CDK4/6 inhibitor in second line, they have to pay it only for 8 and 1 month. So thereby having cost effectiveness. And we are not harming the patient. The overall survival in both the arms were roughly 48 months. So whether you use CDK4/6 inhibitor in first line or second line on progression or initial hormonal therapy does not make overall survival difference for our patients. So this is a reassuring trial that in response setting, we can just give hormone therapy, which is easily tolerable, oral therapy for most of our patients, and add a CDK4/6 inhibitor, which is slightly more toxic in second line in hormone positive breast cancer. And now with the advent of generic CDK4/6 inhibitor, they are simple tablets which have become really cheap. There is a retrospective publication from Pakistan whereby Aziz et al. Whom have shown that high out of cost has come down compared to original palbociclib, and it is roughly 50% cheaper. And it maintains good progression-free survival in second line and in heavily pre-treated patients also. So such ultra-radiant approach increases overall patient access by roughly one-third of patients are more able to access it and drastically reduce financial stress on families without sacrificing the efficacy. So if generic palbociclib is easily available, now it is easily available in Indian also, and it costs roughly 1/10 of what original palbociclib used to cost. So CDK4/6 inhibitor are our standard of care either in first line or second line, as we saw in the Sonia trial. Now, even if CDK4/6 inhibitor are not available in some of the countries, then we will not get disappointed. There is a trial called MECA, where metronomic meaning low doses, 3 times a day capecitabine was added to half of the patient, and half of the patient received only AI. So instead of CDK4/6 inhibitor, your patient received continuous doses of capecitabine with AI as first line therapy or AI alone. The progression-free survival of metamicate, which is an easily oral chemotherapy lower doses, was 21 months with compared to 12 months we would expect with single agent AI. And it also led to overall settlement. So giving capecitabine also has survival improvement in first line. So if CDK4/6 inhibitor is not available in countries, then we can give metronomic capecitabine as in therapy in first line and keep CDK4/6 inhibitor as line or use it in patients. It is not that it is the most important thing that is important for our patients. And grade 3 for toxicities are roughly in 50% of patients. That was also that to HFS. HFS are easily manageable with a study from Indian scenario, which has shown just diclofenac gel, a painkiller gel given prophylactically for HFS in hand and foot, reduces the incidence of HFS. So putting together hormone pos putting it together, a pragmatic first line would be to therapy and CDK4 or at least capecitabine as first line therapy and a CDK4/6 inhibitor in second line, if that is feasible. Moving switching again from HER2 breast cancer to HER2 positive breast cancer. In HER2 positive breast cancer, basically could be some form of chemotherapy, whether HER2 directed therapies are not feasible, and therapies like trastuzumab are available. And adding trastuzumab to chemotherapy background, and if pertuzumab and HER2 therapy and pertuzumab is feasible, then that will be a therapy. This is the first importance of trastuzumab was available with your cancer were progressing on therapy, were randomized to chemotherapy alone or chemotherapy plus trastuzumab. And such patients initially were given either chemotherapy alone or chemotherapy plus trastuzumab, and that progress increased by roughly 3 months from 4.6 months and 4 months. This is even in previously treated patients, and it even shows overall survival method. So trastuzumab is a basic limited evidence, limited trial system, which should be given to patients if feasible, because it does not increase side effects significantly, but it does improve overall survival to our patients. Yes, if now there are multiple EM trastuzumab biosimilars, there are plenty of them more available. Yeah, so I was on trastuzumab. Trastuzumab biosimilars, as I've shown in AMA, has approved multiple biosimilars based on their response in neoadjuvant setting or in metastatic settings. And similarly, multiple biosimilars are used routinely in our day-to-day practice in India. And so if biosimilar trastuzumab is added, it leads to price drop, and roughly more 47 patients can be treated if we have a limited constraint for 100 patients that we can treat. If we add biosimilar trastuzumab, then more 47 patients can be treated. So based on country to country, if there is fixed budget or if patient is paying out of pocket, it's better we add biosimilar trastuzumab if feasible for our patient. Now moving on to something complex. Now HER2 has gone way beyond the pocket of most of the Indian patients also. So Cleopatra trial showed that single HER2 may not be sufficient, and if we add second HER2 directed therapy like pertuzumab to baseline of first line therapy of taxane and trastuzumab, then adding pertuzumab increases progression-free survival, and they could show that overall survival increased by 16 months. So it did show an OS benefit. But again, maybe all patients don't need a second HER2 directed therapy, because the resistance mechanism for HER2 directed therapy is amplification of EGFR, and pertuzumab acts on HER3 and not EGFR. So maybe all patients don't need it, or there is mutation in the HER2 itself, gene itself, then even pertuzumab would be useless. So some patients do benefit by adding pertuzumab, but not all patients. So till we have clarity, which is the patient who adds benefit from pertuzumab, maybe pertuzumab is not needed for all patients. But if feasible and biosimilar pertuzumab is available, as it is available in India, and weigh 1/10 of the cost of the originator, then yes, pertuzumab we are trying to use in as many patients if feasible. Otherwise, no. Now moving on to more complex, that in second line, ADCs are dominating the picture. ADCs like antibody drug conjugate like trastuzumab deruxtecan has shown progression-free survival of 29 months. We saw in first line itself it is 18 months, and then with TDM1 it was only 7.2 months. So TDXD is more beneficial compared to TDM1 in second line. This just give a background. Then in first line, would TDXD would be more better. So this is Destiny Breast 09 trial, which showed that in first line itself, if we give TDXD plus pertuzumab, patient will not progress for roughly 40 months compared to THP. That is we saw in Cleopatra, that is trastuzumab, taxane, and pertuzumab. Patient will not progress in 7 months. So yes, good hazard ratio for progression-free survival, but OS is still not mature, and confirmed response rate does not increase much. But as I was speaking in my previous slide, that if I use TDXD second line, after initial 26 months, if I give to a THP for first 26 months, and then I come to TDXD, then the addition of 2 PFS would be more than 40 months that we see with first line TDXD plus pertuzumab. So maybe if you have to give both of them, then give it first THP and then TDXD. In this trial, Destiny Breast 09, only 10% of patient in THP arm received TDXD. So overall survival benefit will come. But we have to use our brains that all patients did not receive in second line. So a trial similar to Sonia, where we saw whether CDK4/6 inhibitor should be given in first line or second line, would be required to give us an answer whether TDXD is required in first line or second line. Presently, my stance is that it is not useful in first line. And two uh, were triple positive patients. That is, even those who are E hormone positive, they were even given palbociclib on the backbone of TH plus minus pertuzumab. All patients did not receive pertuzumab. Here it is plus minus. And then also in control arm, that is TH plus minus P arm, it was 29 months, as we saw in previous study. And with addition of simple palbociclib and hormone therapy, PFS is reaching 44 months, which is way beyond what we saw with TDXD plus pertuzumab also. So yes, if patient is triple positive, I add palbociclib. If patient is hormone negative, over there also there is some evidence that simple palbociclib oral therapy does act. And in patients with second line TDM1, there is a small 20 patients data that TDM1 plus palbociclib, even in hormone positive negative patients, increases progression-free survival. So we have to use our judgment and add palbociclib in first line itself, even hormone positive, if by after explaining to patient, and maybe there will be never a trial to show that palbociclib is beneficial if added in first line itself. Moving on to easier topic for LMIC, that triple negative breast cancer. So triple negative breast cancer is chemo. First line is paclitaxel, and if patient is BRCA mutated, then addition of platinum, or if patient is in visceral crisis, then addition of platinum to the backbone of taxane. Second line is either capecitabine or eribulin as per feasibility and tolerance of the patient. Third line is gemcitabine or vinorelbine. And then later line would be to give whatever has not been used previously or re-challenge with one of the drugs which has been used previously. And if patient is BRCA mutated, BRCA gene, then maybe you can add olaparib, introduce a PARP inhibitor like olaparib, or add platinum to such patients. So for low cost, it is very easy that single agent chemotherapy rather than combination chemotherapy combination, because combination increases response rate and progression-free survival, but are not able to increase the overall survival of our patients. So combination not first line therapy. Drug to keep in mind is paclitaxel, capecitabine, gemcitabine, eribulin, or metronomic oral therapy for low so there is an evidence of VEA phase 2 single arm study that progression-free survival was 6.4 months and very less severe toxicity. So if patient frail or coming from far off, then maybe can be an option. Patients for a BRCA mutated oral therapy and has been compared to chemotherapy, and this oral therapy had cancer roughly 50 was better in simple oral therapy of olaparib, and but it did not show overall survival benefit. So if and because it but adding they are otherwise sensitive and they want most of their chemotherapy, that is no overall survival. Now moving on to something complex, where that is pointed in chemotherapy has shown that if pembrolizumab is added, a progression in patient with CPS more than that, worldwide government agencies have approved case of more than 10 survival increase from 5 months to 7 months. It has led to overall survival benefit, that is adding immunotherapy to chemotherapy backbone increases overall survival. But still, I normally would in resource limited setting would add a value filter that CPS more than 20 to add immunotherapy. And why do I say so? Because if forest plot, if in keynote 555 in patient with CPS of less than 20, the hazard is near 1. So it does not add significant value, but maybe in patient with CPS of the hazard ratio is below less than 1, and so just 1.01, so it adds benefit to such patient. And because of CPS, all comers with CPS, and also the hazard ratio is less than confidence interval of hazard has been approved by the governmental agency. Now, immunotherapy again has conflicting data. If we from atezolizumab, there are two conflicting trials. One showed progressive benefits no much benefit is question mark. Tempted to use immunotherapy. There is resource constraint. Maybe we can extrapolate where we tried. There are two Indian trials that I'm depicting. One is in the neoadjuvant setting, Planet trial by All India Institute of Medical Sciences from India, where instead of 200 milligram pembrolizumab every 3 weekly, they have only given 50 milligram, and that to every 6 weekly with standard of care neoadjuvant chemotherapy, and they have increased PAT-CR, yet to show overall survival benefit. But PAT-CR is almost similar to what we will see with pembrolizumab. And we have done a multi-site study from our own institute, where we use ultra low dose of nivolumab. The normal standard dose of nivolumab is 240 milligram. We used only 20 milligram in sites, and TNB is not TNBC specific. But we showed that even low dose immunotherapy has very less side effect compared to standard chemotherapy. There is progression-free survival is not inferior, and overall survival is almost similar to chemotherapy. And this study where carboplatin plus nivolumab in low doses, a randomized patient available progression survival is not inferior to what will do. So in those constraint setting, maybe low dose of immunotherapy can be used. And if at all you have to use full dose, then keep a cutoff of CPS of more than 20. Then metronomic oral chemotherapy, we normally say oral endoxan, oral cyclophosphamide is poor man's Parka in Parker, because it is also damaging agent, does not let a tumor repair its own DNA, or use the show of combination of vinorelbine and capecitabine. It continuous dosing, so patient can take at home or nearby resources, and not much toxic. One should have a trained nurse and other support staff to improve the quality of care in such metastatic patients from before week 8 itself, and leads to increase in quality of life for metastatic patients. So to conclude, early palliative integration is most important. Resource-tired systemic algorithm should be there so that we deploy exact biological agent mapped to available facility types and economic work around that. If there is no burden on the government or the caregivers, and optimal in resource limit setting is not simply lesser care. By embracing the clinician deliver the highest possible standards of reputable evidence-based care within the realities of their environment.
Thank you so much. Our next speaker for the session is, it is an honor to welcome Honorable Professor Dr. Sarbani Kaushalaska.
Good evening, and thank you for that kind introduction. I will then, over the next 15 minutes or so, I will share my experience with regards to delivering radiotherapy in both the curative as well as the palliative setting for head and neck cancers. So to begin with the topic, I think most of you in the audience would know what radiation therapy is. It is the use of electromagnetic rays for the treatment of malignant and non-malignant conditions. And we owe this to the discovery of X-rays by Willem Conrad Röntgen, and of course, artificial radioactivity and natural radioactivity to Marie Curie and Henry Becquerel. The way radiation acts is essentially by the direct action and indirect action. And we do understand that since most of our cells are made up of water, it is very important that when photons interact with matter, most of the action of radiation with any kind of matter actually happens with the indirect action. We also need to understand the 5 R's of radiotherapy, which have today become the 6 R's of radiotherapy. And they take into account the 7 R's actually. In addition to repair, reoxygenation, radiosensitivity, reassortment, repopulation, we also take into account reactivation and regeneration of cells for looking at the efficacy of radiation therapy. There are certain treatment parameters that we need to keep in mind when we are talking about the efficacy as well as the toxicity of radiation therapy. And these include the total dose that is delivered, the dose per fraction,
the overall treatment time, the time interval between fractions, and any concurrent therapy that we may use with radiation therapy. And today we know that we can use systemic therapy of various kinds, that is chemotherapy and targeted therapies. And essentially what we do remember when we talk about radiation therapy is the total dose delivered, the dose per fraction, and the overall treatment time. Now, conventional fractionation owes its origins to the RAM experiments that were performed early on in Paris. And what we talk about as conventional fractionation today is 1.8 to 2 gray per fraction, one fraction per day, 5 days a week, and 10 gray per week is what we deliver as conventional fractionation. And it is very important to understand this form of fractionation because when we talk about any kind of fractionation, this is what we usually refer to. Now, there is another thing, this I have already talked about, that is the 7 hours of radiotherapy. Now, in head and neck radiation therapy, it is very important to understand about the types of fractionation, and simply because we do talk very often about the hyperfractionation schedules, the accelerated fractionation schedules, and the hypofractionation schedules. Now, these are important because they determine not only the efficacy of radiotherapy, but also the toxicity of radiotherapy when we talk about radiation therapy in head and neck cancers. Now, why do we need fractionated radiotherapy in cancers in particular and in radiation and in head and neck cancers specifically? That is because for the normal tissue, it is important between radiotherapy fractions to repair itself. For the tumor tissue, this is necessary so that the more radio-responsive part of the cell cycle is exposed to the effects of radiation therapy, and that can lead to cell death. Now, it is important to also understand the types of radiotherapy, teletherapy and brachytherapy. And also, of course, teletherapy, when we talk about it, the origin of the radiation, the source of the rays, and the rays, the energy, the Dmax, and the cost of radiotherapy. When we talk about brachytherapy, that is when radiotherapy is placed in close contact with the body or within the body. In head and neck, we have interstitial radiotherapy, we have intracavitary radiotherapy, surface mole, endoluminal, and endovascular radiotherapy. Of course, today we have added to this armamentarium by adding particle therapy in the form of proton beam therapy and carbon ion therapy. And of course, recently even BNCT is much talked about. Now, when we talk about proton beam therapy, it is essential to understand the physical aspects. When we talk about photons, that is the routine radiation as we use it today, we talk about pockets of energy which have no mass, no charge. They travel through the body and exit from the other side of the body. And the maximum dose is delivered near the skin. When we talk about proton beam therapy, it is essentially particle therapy. They're heavier than photons and they're positively charged. They travel a limited and controlled distance in the body, and is usually there is no dose beyond, as this cartoon clearly shows. And actually, the maximum dose is deposited at a particular depth that is designed by the physician and the physicist. This is typically the kind of distribution that we get with photons as well as protons. And these are actually the biological aspects of photon beam energy and proton beam energy. Mode of DNA damage is slightly different between the two kinds of radiation. The repair is also different between the two forms of radiotherapy. And the linear energy transfer, as we call it in radiation oncology, is low in case of photons and higher in case of protons. And of course, the relative biological effectiveness when we talk about photons and protons is almost the same, but maybe slightly higher in the protons towards the end of range. These are the kind of machines that are available for the treatment of our patients today. And this, of course, is the Proton Beam Therapy Center at the TMC, which is located at Actrec in Kharghar. And we have treated more than 29 patients with head and neck cancers with proton beam therapy. Now, when we talk about optimal management, we talk about the patient at the center of everything, with the oncologist, the diagnostician, the rehabilitative services, and the supporting services. Now, what is the role of radiotherapy in head and neck cancers? When we come to head and neck cancers, in the primary setting, external beam radiotherapy may be used in early disease when the patient is intolerant of surgery, early disease with poor cosmetic outcomes, at surgery, for example, lip lesions involving the commissure, unresectable disease usually combined with chemotherapy, and advanced disease not suitable for surgery due to poor performance status or comorbidities. We can use interstitial brachytherapy also in the curative setting with radiotherapy, and this essentially includes early and superficial well-defined tumors located more than 5 millimeters from the bone, accessible, and those are actually node negative. In the adjuvant setting, radiation therapy is used in the presence of unfavorable pathological features combined with chemotherapy for positive margins and extracapsular nodal extension. It can be also used when we use brachytherapy alone for the positive resection margins in combination with external beam radiotherapy. It is important to initiate the radiation therapy on time and to also see that the wound has healed completely. Look at wound complications and various comorbidities. This is very important that we ensure that the wound has healed completely and within time so that we can initiate adjuvant radiation therapy within time. In the salvage setting, it can be used for adjuvant therapy after salvage surgery or in primary treatment. It may be the primary treatment modality, usually combined with chemotherapy if further surgery is not feasible. Interstitial brachytherapy may also be useful in this situation for persistent or recurrent disease after previous radiation, second primary cancer occurrence within previous radiation fields. These are the factors that we use or decide, which help us decide on the use of adjuvant radiation therapy. In early stage disease, essentially in the curative mode, it is usually a single modality of treatment, which can be radiotherapy alone, or it can be radiotherapy with a brachytherapy boost, or it can be surgery alone. In advanced stage disease, it's usually multimodality therapy, surgery with adjuvant chemoradiotherapy or radiotherapy alone, concurrent chemoradiotherapy using platinum-based regimes. Where patients are not suitable for platinum, we can use concurrent radiotherapy with other agents. Altered fractionation schedules may also be used, like hyperfractionation, accelerated fractionation without total dose reduction, which I had already showed you in the beginning. Now, it is important that in the curative setting, we select the case appropriately. We may irradiate prophylactic volumes because we understand in head and neck cancers that the disease has a tendency to spread to the regional lymph nodes. Appropriate immobilization has to be used. It is mostly conformal. Mostly protracted schedules are what are used, and verification in the department is very essential depending upon the infrastructure that is available. Now, brachytherapy, as I've said, in head and neck cancers is an important armamentarium that we have, and these are usually either used radical or in the radical setting or in a combination with external beam radiotherapy, and I've already told you the indications. The relative contraindications, of course, include unfavorable histology, extensive leukoplakia at the margins of the lesion, deep infiltrative growth, and high risk of nodal metastasis. These are a few examples of clinical pictures of a few of the patients who could do well with giving with the brachytherapy alone. And this is the kind of procedure we insert needles, which are replaced by tubes. And then, of course, these are in different that the patient has been, the pictures have been taken. And of course, we do a computerized dosimetry to establish that we are delivering the radiotherapy to the right place and structure. Now, the goal of any radiation therapy so far that I've talked about is essentially to deliver the highest dose possible to the tumor and lower doses to adjacent normal structures, thereby seeing that we have an optimal therapeutic ratio. Now, these are the various complexities that we may have in the head neck region. This is a child. I borrowed this slide from Dr. Laskar. And of course, this is a tumor in the nasopharynx. And we have to realize that when we radiate structures in the head and neck region, of course, we have structures that differ in their tolerance to the varying doses of radiation therapy. We have structures like the eye, the optic nerves, the brainstem, the spinal cord, the parotid glands. And all these structures have doses of tolerance that are different from the doses that we need to deliver to these structures to the disease. And this is what is the kind of dose schedule that we do deliver to our patients. And we need to keep this in mind when we are drawing various targets as well as structures in the vicinity of these targets. This is a table showing you the tolerance of the various structures within the head and neck region. Now, another very important aspect of treatment delivery is prophylaxis. We need to counsel a patient about the intention, duration, do's and don'ts on radiotherapy, the consent that we need to take, nutrition counseling, speech and language, occupational and physiotherapy, dental prophylaxis, and any other form of prophylaxis or evaluation that we need to do at baseline and afterwards after completion of the radiotherapy, which in cases of patients with the nasopharynx could be a complete endocrine evaluation, audiometry, ophthalmology, etc. Now, when we do external beam radiotherapy, the process is very important. Patient positioning and immobilization, accurate delineation of the areas to be treated, accurate delineation of areas that have to be saved, treatment planning and optimization, treatment delivery, treatment verification, storage, and retrieval are equally important. This is a picture of a patient on whom we are planning for radical radiotherapy, and an immobilization mask has been made. An appropriate imaging is also essential when we are planning patients so that we can contour or delineate the target volumes accurately. Now, volumes in radiation therapy for the head neck area essentially include the gross tumor, a margin for this gross tumor, and of course the lymph nodes that may be at risk. These are a few guidelines that are available for the delineation of these target volumes. And of course, we have the various ICRU systems that are available to help us delineate in a more reproducible manner between various centers. Now, when we look at patients, we have to actually sometimes end up treating very large volumes. And clinicians in the audience will understand that this is a picture of a patient with a nasopharyngeal tumor. And this is a long length of tumor that we have to treat. Various organs at risk do appear when we are treating these cancers. And it's very important for us to be able to save them, especially when we are treating in the curative setting. And radiation therapy, of course, has evolved from squares to much more conformal techniques. And this is important, and it is important for us not only to know this evolution, but also to understand the reason for this evolution. So the clinical motivation for this kind of conformality has essentially been that more conformality leads to better sparing and improvement in the therapeutic ratio. So we've become more squares to more shaped beams and shaped doses also. So we can, if we do not have the means to do that, we can of course do more shaped fields, and these can be done on the modern linear accelerator. And as I've already told you, this leads to improved tumor coverage, better critical tissue sparing, possibility of dose escalation, and improvement in local control rates and survival. And these are the various structures in the head and neck, a huge length. We actually contour about almost 26 organs at risk for every patient where we do conformal radiotherapy. And this is the kind of distribution that you can get with our radiotherapy. Sometimes the volumes in radiotherapy in head and neck cancers can be quite complex, and it is very important for us to then think about what would be the best technique, with keeping in mind not only the control rates, but also the toxicity of these patients. These are the various technologies that are available to us today. So next we go to treatment planning. We have the 3D CRT process. Then we have the various delivery processes and the various delivery machines. And this is the latest machine, that is the proton machine that we do have today. And these are the various, again, a list of the various delivery systems that we have in radiotherapy. Of course, where we do not have recourse to these high-end technologies, we could make simple accessories to kind of save the normal structures as far as possible, so that patients can enjoy a good quality of life. So we've moved from these various fields to actually more shaped fields and shaped beams, so that patients can enjoy a better quality of life. It's not only important for us to treat these patients, but it is essential for us to verify that what we've planned, what we have actually decided to treat is what we are treating. And that is why it is important to have various verification protocols. Like this is a picture of a DRR. This is a picture of an EPID. And of course, this is very important. So we have various systems that are available, the EPID, the DRR, as well as the cone beam systems. And today we do use image-guided radiotherapy. wherever possible, wherever available, so that we can spare adjacent normal structures. Because not only does the tumor change shape and size on treatment, but so also do the normal tissues. It is important to also understand the side effects of radiotherapy, and they have been broadly divided into acute side effects, chronic side effects, and specific side effects in the head and neck area. And these are a function, they're usually self-limiting, but they are a function of the total dose, the volumes of tissue irradiated, the energy or type of radiation given, use of radiosensitizing drugs, location of treated areas, and treatment technique that is used. General approach would be to identify, prevent, preempt, protect, and treat wherever the conditions can be treated. And of course, then maintain a patient in his or her good condition. Nursing care is very important on radiotherapy. There are various side effects that are related directly to radiation therapy of the head and neck area, like a dry mouth. And of course, mucositis is something that occurs in almost all patients. The severity and grade is a function, again, of the factors that I've already spoken about. And then fatigue does sometimes come with all these fancy techniques that we use today. Dysphagia can be a problem that we do have. Anorexia, dental care is paramount to having good outcomes with radiation therapy in the head and neck area. I'll just show you some case examples. This is a planning for T1, T2 glottic cancer, one of the success stories of radiation therapy. And today, of course, we've moved to more conformal therapies. You can see that we can just irradiate the single cord like the surgeons do. And we can, in that process, actually spare the doses to the adjacent structures like the contralateral what you got, arytenoids or the carotids, and hence spare the patient from toxicities like stroke, etc. Now, coming to palliative radiation therapy and advanced disease, we do often come across disease like this, which has huge fungating nodes. So what are the symptoms that are associated with advanced metastatic disease? Pain, dysphagia, bleeding, dyspnea, ulceration, cancer, cachexia, fatigue. And radiation therapy can be used effectively to palliate symptoms like pain, dysphagia, and bleeding. Of course, the options are either single modality treatment or multimodality treatment, depending upon the intent of treatment that we have in mind. The particulars that we need to keep for radiation therapy is that we select usually hyperfractionated schedules when we think that the intent is palliation. The volumes are usually limited. Conformal techniques whenever possible. Select the right patient. Less of investigations. These are various publications. These are various hyperfractionated schedules that have been described in literature. And these are the kinds of patients where we cannot use palliative radiotherapy. Please keep this in mind. And it is always important for us to keep supportive care in mind, because provision of the appropriate nursing care, emotional support, monitoring, coordination, health education. So what is important is a multidisciplinary approach, a team effort, and judicious use as part of combined modality for treatment of most solid tumors. These are the various kinds of machines that we have. And of course, if we do not have access to these modern machines, we can still give good radiotherapy using certain conventional accessories. And I'll be happy to take any questions. Thank you very much.
Let's take our next speaker. It is our privilege to welcome Honorable Dr. Amita Maheshwari.
So, very good afternoon. And at the outset, thank you, Merck Foundation and Dr. Siddharth Laskar for the invitation. So what I'm going to discuss is management of advanced ovarian cancer. But before I go to that, I think we are really missing you guys physically being with us. That's what we thought, that you all would be coming to Mumbai, and we will host this in our renovated auditorium, but maybe next time. So let me start this presentation with a clinical scenario. A 63-year-old lady with abdominal distension progressively increasing, otherwise no comorbidities. When we presented to us, her peak, performance status was 2. She had hugely distended abdomen with gross ascites, and on clinical examination, there were bilateral head and neck cell masses. We did a CT scan which showed ascites. You can see deposits. Those dark areas are liver surface deposit, splenic deposit. There were some para-aortic lymph nodes, and there was huge ascites along with pelvic masses. We did CA-125, which was elevated. We also do other tumor markers like CEA and CA-19-9, just to rule out, GI primary malignancy. So always do at least CEA and CA-125 in advance clinically suspected ovarian cancer, which may look advanced. And her serum albumin level was 2.9. So the question is, and this is a typical presentation of advanced ovarian cancer. So the question is, do we do upfront surgery or give her chemotherapy first? And the other question is, what is the role of heated intraperitoneal chemotherapy in advanced ovarian cancer? So when we look at ovarian cancer in India, actually it's the third most common gynecological cancer in overall cancer in Indian women after breast and cervical cancer. In African continent, it is the fifth most common cancer. With over 25,000 new cases diagnosed every year. Of course, there is, a variation amongst various countries. So Ghana has the highest incidence of ovarian cancer. Now, I think the importance of ovarian cancer is just beyond numbers, because large majority of ovarian cancers, they are diagnosed with advanced stage disease. And despite so many advances happening in the field of oncology, we still don't have a good screening test, which can pick up ovarian cancer in early stages. And this will be a typical presentation of ovarian cancer. Why this happens? I think because of the location of ovaries, they are normally exposed to peritoneal cavity, and any abnormality happening in ovaries has very early opportunity to spread inside the peritoneal cavity, and that's how most large majority of ovarian cancer patients, they would present with advanced stage of disease. So, conventionally, the treatment of advanced ovarian cancer has been primary cytoreductive surgery, followed by platinum-based combination chemotherapy. And the goal of this surgery is to remove as much disease as possible so that we achieve what we call optimal cytoreduction. The ideal would be no gross residual disease seen to naked eye, but if not that, at least individual tumor size should be less than a centimeter. And why this concept of optimal cytoreduction is so important in ovarian cancer, because many studies have shown that the disease we leave or we are not able to remove at the end of surgery is the single most important prognostic factor. So there is a meta-analysis which showed that every 10% increase in cytoreduction rates was associated with 5.5% increase in median survival. So as a surgeon, whenever we are doing surgery, we should make every effort possible to remove as much as possible. But the problem is, when we are doing primary cytoreductive surgery, there is such extensive and aggressive surgeries may be associated with significant surgical morbidity, which may range from 10 to 70% in various studies have reported. And there can be some amount of, certain percentage of patients may die during perioperative period. And what is also important to note, despite such aggressive effort, optimal cytoreduction rates have been reported only to 40 to 50%. That means despite very aggressive surgery, in a substantial number of patients, when we are doing surgery first, we may not be able to remove maximum disease and achieve optimal cytoreduction. So primary cytoreductive surgery is not for every patient with advanced ovarian cancer, and it should not be done by everyone. The alternative is neoadjuvant chemotherapy. And now we have enough evidence to suggest that neoadjuvant chemotherapy in advanced ovarian cancer, where optimal cytoreduction at upfront surgery is not possible, it gives equivalent survival. So there are, at least two large randomized trial, URTC study and CHORUS study, which compared neoadjuvant chemotherapy to primary debulking surgery and showed there was no difference in survival and better toxicity with neoadjuvant chemotherapy. There was another Japanese study which also showed similar results, and Scorpion study showed increased toxicity in patients when primary debulking surgery is done in advanced ovarian cancer. So this is just to show perioperative complications. They are higher when we do surgery first in patients with advanced ovarian cancer. So the question is, should all patients with advanced ovarian cancer be treated by neoadjuvant chemotherapy, and should we not be doing primary debulking surgery at all? The answer is no. What we need to do is we have to select patients judiciously. So how do we decide which patient? So we take, three main important considerations. One is disease related. That means when we do preoperative evaluation, pre-treatment evaluation by clinical examination and imaging, and a surgeon feels that it's unlikely that we will achieve optimal cytoreduction. So, for example, if imaging shows disease, bulky disease in upper abdomen, if there are metastases at porta hepatis, diffuse peritoneal carcinomatosis, stage 4P disease, parenchymal liver mets, or extra abdominal disease, and when multiple bowel resections are anticipated, these patients are better managed with neoadjuvant chemotherapy. And if we are not sure based on imaging alone, a laparoscopy can be done, a diagnostic laparoscopy can be done to assess the extent of disease. And if we think it's too extensive, just take a biopsy and close and send the patient for neoadjuvant chemotherapy. The other factor to be to be considered is patient related. So performance status of the patient, albumin, if it's very low, that suggests that patient will not be able to withstand a very aggressive surgery. Elderly, any associated medical comorbidities like recent history of deep vein thrombosis, MI, or any other comorbidities. And the third, and I think very important factor in our kind of settings is infrastructure. So, unless we have just not surgical expertise, but we also need to have good anesthesia and ICU facilities, also interventional radiologist, and very important that patient should be able to afford expensive treatment. So after surgery, if patient requires total parenteral nutrition or high-end antibiotics or ICU stay. So patient and family should be, or we should have finances as well as infrastructure to take care of these patients. As I said, that in case in doubt, we can use laparoscopy to know whether upfront surgery or neoadjuvant chemotherapy. So recently, TRUST trial, which compared primary debulking surgery versus neoadjuvant chemotherapy, abstract was presented. However, full text is still awaited, and we really don't know. The primary endpoint of TRUST trial was overall survival, and whatever abstract it showed that it did not meet the primary endpoint. That means there was no statistically significant improvement in overall survival. However, progression-free survival was better in patients where upfront surgery was done. But this was again very selective patients who were fit and suitable to undergo primary debulking surgery. When we give neoadjuvant chemotherapy, I think one thing in the first presentation, Dr. Tanuja said oncology is all about pathology, and I absolutely agree with you. Before starting neoadjuvant chemotherapy, we have to be sure that we are dealing with cancer, one, and we are dealing with ovarian cancer. So in our setup, we do see many patients of abdominal tuberculosis. They mimic ovarian cancer. Their CT scan presentation may be like ovarian cancer. Their CA125 can be elevated. So this is we published our experience few years back, and you can see the CA125 in these patients. The average was more than 650, and it could be very high in thousands, and patient may still have tuberculosis. So absolutely necessary to have histopathologic or at least cytologic confirmation of malignancy before starting neoadjuvant chemotherapy. So this is our experience we published few years back. Patients who were treated, advanced ovarian cancer patients who were treated with neoadjuvant chemotherapy, the median progression-free survival was, this is, PARP era, so 15 more than 15 months, and overall survival around 35 months. And in this study also, optimal cytoreduction was the most important factor, both for overall and PFFs in these patients. So surgery, whether you are doing upfront or after neoadjuvant chemotherapy, has to, the goal of surgery is same, that is optimal cytoreduction. And even after some of these images are after chemotherapy, so it's not that everything will be gone and you will be able to manage with a smaller surgery. So there may be still omental disease, diaphragmatic disease. We may need to remove diaphragmatic peritoneum or even resection of the diaphragm. So this patient had a large deposit over the liver surface adherent to the diaphragmatic pleura, required resection of the diaphragm, and these defects can be either closed primarily. In this patient, we did primary closure, or if defect is very big, we can put a mesh. So what I'm trying to say this, you can see necrotic, this was post-chemotherapy disease. But, it's not that surgery is always easier after chemotherapy, but I think even aggressive surgeries, patients tolerate well after neoadjuvant chemotherapy. They may be, may require to remove surface deposit if there is a disease, as splenic hilum, splenectomy with or without pancreatectomy, and bowel resections and anastomosis. So the next point is, should we always remove lymph nodes in patients with advanced ovarian cancer? So if we are doing primary debulking surgery and if lymph nodes are not enlarged on clinical assessment and on imaging, there is no need to do complete lymphadenectomy. So there was a phase 3 randomized trial which showed that removing lymph nodes in these patients, if you're doing upfront surgery and there are no lymph nodes, it doesn't really improve survival. It just adds to the morbidity after surgery. So although nearly 56% patients may show pathologically positive lymph node, it does not translate into improved survival in these patients. So what this Lion study showed, that there is no advantage of doing routine systematic pelvic and para-aortic lymphadenectomy in patients when lymph nodes are not enlarged and patients undergoing upfront cytoreductive surgery. Now, how about neoadjuvant chemotherapy setting? So there is no randomized trial, but whatever studies and meta-analysis we have, it showed that, if lymph nodes are not enlarged during surgery, or if they were not enlarged pre-operatively, there is no need to remove these lymph nodes if we are, even if we are able to achieve optimal cytoreduction inside the peritoneal cavity. So that's the guidelines. A routine lymphadenectomy is not recommended. However, if lymph nodes were enlarged prior to chemotherapy or if they are enlarged during assessment, then those nodes should come out. Small tips, if you are doing RPLND1, the most important is adequate exposure and to have proper instrumentation, proper anesthesia. You may need these, accessory things, including loops and suture material, Proline 5060 in case injury happens. Need to have monopolar and bipolar cautery or harmonic or ligashore, one of those energy devices. A very important thing if you are doing RPLND for any indication, the first and the most important thing is to have adequate exposure and a long vertical incision so that you are not compromising in your axis, and or use Thompson or any other self-retaining retractor. I don't know how much time I have. There is a small video on RPLND. So, this patient was clinically otherwise confined to ovary, but there was a large lymph node in retroperitoneum. So we removed that node, followed by whatever lymph nodes were there. Non-enlarged nodes also need to come out. And when we are doing lymphadenectomy for ovarian cancer, it's just not low para-aortic. It has to be all the way up to renal vein. So both, and that's how it should be at the end of surgery. You can see IVC, left renal vein. These are lumbar veins, aorta, and inferior mesenteric artery. This fine thread-like thing is superior hypogastric plexus. So, chemotherapy, whether it's you are using in neoadjuvant or adjuvant setting, for first-line chemotherapy for ovarian cancer is combination of paclitaxel and platinum, carboplatin and paclitaxel. So we generally use carboplatin AUC 526, platinum in a dose of 135 milligram per meter square. And the preferred regimen is every 3 weeks. However, patients, if you think their performance status is poor, weekly regimen can also be used, where carboplatin is used in a dose of AUC 2 and paclitaxel it's 60 to 80 milligram per meter square. Bevacizumab we don't use routinely in frontline setting, but if patients have recurrent or refilling ascites or pleural effusion, there bevacizumab can be added. A word about HIPEC, whether we should be doing for all cases or not. So there was a study, large randomized trial, which compared HIPEC to no HIPEC in interval debulking surgery in patients where optimal cytoreduction was achieved. And what this OV HIPEC 1 trial showed that patients who underwent HIPEC after optimal cytoreductive surgery, they have improved progression-free as well as overall survival. So this study, kind of showed that there is some role of HIPEC, and as a result, HIPEC has been included in NCCN guidelines as one of the option. However, it's not really uniformly practiced across the globe. There was another small trial, same time, looking at the role of HIPEC both in frontline and neoadjuvant setting. It failed to show survival benefits from HIPEC, especially in frontline setting. So currently, I think there is controversy about HIPEC. And at Tata, we are running a large phase 3 trial, 3-arm study where we are comparing heated intraperitoneal chemotherapy to normothermic intraperitoneal chemotherapy and no intraperitoneal chemotherapy. Now, why we added normothermic? Because we thought that HIPEC, one, complications related to heat, and second, the HIPEC is expensive and it needs machines. So in low resource setting, if normothermic intraperitoneal chemotherapy is as effective as heated intraperitoneal chemotherapy, I think that it can substitute HIPEC. So it's an ongoing study and sample size of 450 and have, I think, so because of extensive disease, poor performance status and low albumin, we started her on neoadjuvant chemotherapy, 3 courses of paclitaxel and carboplatin. She had good response to chemotherapy and interval debulking surgery was done. So this was her video at that time of debulking surgery. As I initially mentioned, surgery after neoadjuvant chemotherapy may not always be easy or very simple. So this lady has a significant amount of disease even after neoadjuvant chemotherapy. So this is, what we are doing is removing diaphragmatic peritoneum. This was falciform ligament, which also had disease. And these are some of occult or hidden areas one should carefully look for. And unless we take a long vertical incision, go all the way up, we will miss out the disease. So this, you can see base of falciform, there was a big nodule. So, we are lucky to have various energy sources available to us. If not, then even, bipolar or monopolar cautery is good, but otherwise Ligashore or harmonic are good in such cases. So you can see there was extensive peritoneal disease. Diaphragmatic peritoneal has disease all the way. So entire peritoneum was removed. Now there was some disease at hepatorenal pouch also. So we mobilized the liver. Once you think there is disease, liver mobilization is required. Otherwise, again, will not be able to remove the entire disease. This is hepatorenal pouch. You can see Girota's fascia. So the entire peritoneum. And once we mobilize the liver, we could see another deposit there. So this was also removed. And, non-anatomical small liver surface deposits, they are very easy to remove. You don't need GI surgeon for this. This is Gleason capsulectomy. So there was disease or irregularity over a liver's capsule. So that was also removed. So by doing all of this, we could achieve no gross residual disease in this patient. And also important component nowadays is genetic testing. All patients, regardless of their age, or family history must counsel and be referred for genetic testing, at least BRCA1 and 2, if possible, the extended gene panel. But if not, at least BRCA1 and 2. So our patient turned out to be BRCA1 mutant. After adjuvant chemotherapy, we put her on olaparib. She continued that for 2 years and doing fine. So just last, what we should not do to a patient with suspicious adnexal mass. This is, early stage ovarian cancer, they present as suspicious adnexal masses. And what we should not do, I don't know about you all, but in India, there is craze for doing laparoscopic surgery by a generalist. And ovarian masses, especially in young girls, they invariably do laparoscopic cystectomy or salpingo-oophorectomy with spillage, with contamination. So this is something absolutely no. We should not rupture a ovarian mass. Of course, we often don't have preoperative diagnosis of cancer in these cases. But what is important to remove these masses intact, because spillage can adversely affect the prognosis. And in many patients who otherwise had early stage disease, young patient where fertility preservation was possible, but we could not preserve fertility because by the time they, after laparoscopic rupture and upstaging, when they presented to us, there was extensive disease, and some of them actually succumbed to their disease. Otherwise, they were very good prognosis, early stage disease. So to summarize, patients with advanced stage ovarian cancer, they are treated by a combination of surgery and systemic therapy. I have written systemic therapy because it is not chemotherapy. Now we have targeted therapy, PARP inhibitors. The role of immunotherapy is still not as great as in cervical or endometrial cancer. How we schedule surgery and systemic therapy depends on factors which I just mentioned, that it is a combination. Whenever we think of optimal cytoreduction, upfront will be possible, upfront surgery, otherwise neoadjuvant chemotherapy to downstage the disease and to make patients overall condition better to tolerate aggressive surgery. Surgery, even after neoadjuvant chemotherapy, may be quite extensive and aggressive. So it is not just TH and BA, so just hysterectomy, salpingo-oophorectomy, and omentectomy. It should be a proper cytoreductive surgery. So detailed workup, including histopathological confirmation of diagnosis, tumor markers, and imaging, are essential prior to treatment. One should always rule out GI primary or any other malignancy when dealing with advanced suspected advanced ovarian cancer. Genetic testing must be offered to all patients. So this is some area one should invest, because now PARP inhibitors have shown to improve survival, and also if germline positive, there is implication for other family members, and a lot of preventive strategies can be offered to unaffected healthy individuals. So we are in the era of personalized medicine, and the way we work, no one person can decide for the patient. It has to be multidisciplinary team. So this is some of the members of our gynec oncology group. Medical oncologists, radiation oncologists, pathologists, molecular biologists, and genetic experts, and radiologists, all of us, and of course, occupational therapists, and most important are our residents. So we all work together. And at the end, I think oncology is more of combination of art and science when we deal with our patients. Thank you so much for your kind attention.
Let's move on to our next speaker. I would like to call upon our next speaker. We are pleased to welcome Honorable Dr. Naveen Khatri. He is the Deputy Director and Professor, Department of Bone Marrow Transplant Unit, Advanced Center for Treatment, Research and Education and Center.
Thank you very much for inviting me for this meeting and to deliver a lecture on bone marrow transplantation. So what I'm going to do in the next 15 to 20 minutes is to give first a basic introduction of what bone marrow transplantation or hematopoietic stem cell transplantation means, and then what is the status of transplantation across the Asia Pacific region, India, and a little bit about the West. So what is hematopoietic stem cell transplant? It is basically an intravenous infusion of autologous, that means self, or allogenic, that means from a donor, hematopoietic stem cells. These stem cells are either collected from the bone marrow, the peripheral blood, or the umbilical cord. And what these stem cells do is to re-establish the hematopoietic function in patients who have either damaged, defective bone marrow or immune system. And this treatment is potentially curative for a large number of both hematological and immunological diseases. Now, essentially, transplants are of two types. The first, or the simple one, is autologous transplant, where you take hematopoietic stem cells from the patient, him or herself, and then reinfuse to the patient after some high doses of chemotherapy. And then the allogenic transplantation, which is a more challenging transplant, where you have a donor who donates hematopoietic stem cells to a patient. Now, this donor can either be a fully matched related donor, fully matched in the sense that the HLA is fully matched. And this is typically a brother or a sister who's fully matched to a patient. It could be a matched unrelated donor. Now, the match unrelated donor means that this patient has an HLA typing which is just by chance matched to any voluntary donor who has pledged to give his or her marrow in unrelated registries across the world. And this is done by searching various registries for a match. Or it could be a haploidentical donor where the HLA is half match to a patient, and this is typically parents of a patient or children of a patient or siblings of patients who can be half matched to the patient. And the last is cord, where the cord is matched, HLA matched to a patient. There are multiple cord banks across the world, and just by chance, there is a cord which is matched to a patient, and then the transplant can be done. So essentially, for allogenic transplant, you have a patient, you do a HLA typing with a suitable donor. You find that the suitable donor is matched, either full or half matched, and then you give patients conditioning chemotherapy with or without radiation. That is to knock out the patient's bone marrow so that the donor cells can then home into the patient's marrow and then engraft. And then after that, it's a period of 14 to 20 days where the blood counts of the patient remains low. And once the count starts rising, those are counts which are because of the donor cells which have engrafted in the marrow, and then the patient gets discharged. Now, essential to allogenic transplant is HLA typing. Now, all of us inherit one set of HLA from our father and one set of HLA from our mother. So essentially, if there is a family of 4 or 5 siblings and there is a patient who requires bone marrow transplantation for any reason, then there is a reasonable chance that one out of those 4 siblings would be matched fully to the patient, and that's 25%. 2 out of those 4 siblings would be half matched to the patient, and these are known as haplotransplants, which are done, and one of them will be of no match. And this is how the HLA typing is worked out for a patient. Now, what is autologous transplant? Here you have a patient, you take the stem cells of the patient, then you give chemotherapy to the patient, high doses, to eradicate the disease for which the autologous transplant is being done. Sometimes the stem cells are cryopreserved so that it can be used at a later date for the stem cell infusion. Then after the chemotherapy, stem cell infusion is done. And then after 14 to 20 days, after the counts go down and the count starts coming up because of the stem cells infused, the patient is discharged. Now, the treatment, this curative treatment started way back in 1950s when the first patient of leukemia received a marrow from her identical twin. It was only in 1970s that HLA matched donor transplants were started, which was related HLA match transplants. It was in 1980s that alternate donor transplants were, which means either unrelated or half match transplants, were started in the world. And it was in 1988 that the first cord transplant was done in the world. And this was a very, one of the most seminal example of transatlantic cooperation. The patient was from US, a patient of Fanconi's anemia, and the transplant was done in Paris under Eliane Gluckman, one of the foremost transplant physicians of our times. And the patient was uh, transferred to France for the transplant because this was the first cord transplant which was being done in the world, and the world did not want it to get into any sort of problem. By December 2012, 1 million transplants were done across the world, and currently half the transplants are done in Europe, one third in North America, and some in South America. Around 15 to 20% of all transplants are done in the Asia Pacific region. Dr. Donald Thomas was conferred the Nobel Prize for Physiology and Medicine in 1990 for his pioneering work on bone marrow transplantation. So, as I said, autologous transplant, the stem cells are from the patient, him or herself. These are the easiest transplants to do. They have the least transplant related mortality. However, the relapses are higher with this sort of transplant, and it is done in few diseases where the bone marrow is not involved due to the disease. The allogenic transplants, the match related transplant, the siblings are the next safest transplants to do, where you have an HLA, fully HLA matched related brother or sister to the patient. And in any ethnic race, the chances of having such transplants could be anything between 25 to 50%. The unrelated donor transplant and haploidentical transplants and umbilical cord transplants are much more difficult to do. You need a very well established transplant centers to do these sort of transplant. They are curative to a large extent, but they have higher transplant related mortality. The indications of autologous transplant on the left you can see are for malignancies, the foremost indication being multiple myeloma, followed by non-Hodgkin lymphoma, followed by Hodgkin's lymphoma, and in children, neuroblastoma and some germ cell tumors. And in the right, you have benign disorders like autoimmune disorders, SLE, rheumatoid arthritis, and multiple sclerosis, for which autologous transplant are being done, and amyloidosis, which is a plasma cell disorder straddling between benign and malignant condition. As far as allogenic transplantations are concerned, on the left we have the malignant diseases for which it is curative, and the top ones are acute myeloid leukemia and acute lymphoblastic leukemia, some of the myeloproliferative disorders, and some lymphomas. On the right, you have the benign diseases, of which the foremost is aplastic anemia, the bone marrow failure syndromes of children, hemoglobinopathies such as thalassemia major and sickle cell disease, and immune deficiency diseases such as Wiskott-Aldrich syndrome and severe combined immune deficiency disorder. Now, how do we collect stem cells? We can collect from bone marrow, we can collect from peripheral blood, or from the cord when a child is being delivered. Now, this is how the bone marrow is collected. You take the donor or a patient into a prone position under general anesthesia. The marrow is collected through syringes and then put into this filter bag so that the bone corpuscles and fat globules are removed, and then after that it is infused to the patient. How do you do peripheral blood stem cell collection? These are done through a pheresis machine in which these mononuclear cells are removed, that is stem cells, put them on the machine, and then they are collected. Now, most of the time in allogenic transplant, you give the cells fresh infusion, but in autologous transplant, you may have to cryopreserve them in -80 refrigerators so that it can be used at some other point of time. Now, this cryopreservation requires an agent known as DMSO, which is dimethyl sulfoxide, so that these stem cells don't get destroyed when you freeze them. And this is how you cryopreserve them, put them in these freezers, and when one has to use the stem cells for infusion, then you thaw them on a 37-degree bath and then infuse it. Now, to put a transplant unit together in any country, whether it's a developing or a developed country, or in any center across any part of the country, you need a unit which is designed to prevent infection coming from outside. You need hematologists or medical oncologists trained in transplant. You need excellent nursing staff. You need a facility where cryopreservation of stem cells can be done. You need a 24-hour transfusion medicine, 24-hour microbiology department, and a biochemistry department, a 24-hour pharmacy, a very good hematopathology department. One has to have great relationships with various departments, because this is an absolute multidisciplinary teamwork, just like what Dr. Maheshwari alluded to ovarian cancer. And above all, what it requires is that skilled personnel should have the passion for this discipline and have the ability to work together despite differences. However, one of the most important attribute which is important for setting up units is that the leadership of the institute should be supportive, because this requires a lot of resources for setting up a transplant unit. Now, one of the most important is the room design for a transplant patient. It has to be in a way that the infections from the outside atmosphere does not come in. So for that, you need HEPA filtered rooms so that spores which are less than 1 micron don't come in. And then you need air exchanges like the operation theaters so that it remains clean. These are the sorts of HEPA filters that you require for each room, so that these fungal spores and bacterial spores don't come inside. A transfusion medicine support will need a transfusion medicine department, which should have pheresis machines where stem cell collections can be done, platelet collection can be done. There should be expertise for cryopreservation, and you need a gamma irradiator, to irradiate blood products which are given for transplant patients, because these are the most immune compromised patients. If you don't irradiate the blood products, there's a serious chance of immunological problems that can happen, which is known as transfusion-associated graft versus host disease. The microbiology department should have automated backtrack system, should have the methodology to ability to do various virology PCRs, of which CMV, PCR, adenovirus are the most important. There should be an ability to do various other parasitic or bacterial testing, and of course, measurement of immunosuppressive agents like cyclosporin and tacrolimus. The hematopathology department should have the ability to do flow cytometry for performing CD34 counts on stem cells, and for more sophisticated transplant, more sophisticated diagnostic tests should be able to be done. Pharmacy should be equipped with various chemotherapeutic agents which are required in transplant. Some of the antiviral or agents which are not easily available in many parts of the world, one should have a stock of it. For example, for Scarnet and Cidofovir for anti-CMV and anti-adenovirus treatment, and this should be stocked in pharmacy. A radiation oncology department is also important, because many of the condition regimens for transplant includes total body irradiation. So it is always best to have a radiation oncology department which is equipped to be able to do it. Now I'll come to what is being done in the Asia Pacific region. Now, if you look at the Asia Pacific region, more than 55 to 60% of the world population lives in the Asia Pacific region. Two countries, China and India, nearly forms 35 to 40% of the total population in the world. So this is the region where perhaps you will have the maximum number of patients who will require transplantation. Now, this is the data from the Asia Pacific region. Asia Pacific Bone Marrow Transplantation Group is a society for the transplantation across 23 countries in the Asia Pacific region. This society started collecting data of transplant from these 23 countries from 1986 onwards, and you can see that till 2023, more than 400,000 transplantations have been done in these various countries from the Asia Pacific region. Now, a snapshot of how many transplants are done in this region in a particular year. We have the 2023 data where more than 36,000 transplants have been done in various countries across this region, of which the commonest indication has been the acute myeloid leukemia, 25%, 17% plasma cell disorders, 16% lymphomas, and 13% acute lymphoblastic leukemia. Now, when you break up to the number of transplants done by each country, countries which do more than 1,000 transplants per year, you can see the red line, that is China. They do the largest number of transplants in the Asia Pacific region with more than 20,000 transplants every year, followed by Japan, around 5,000, followed by Korea and India, approximately 3,000 to 4,000 transplants per year. Now, those countries which do between 100 to 1,000 transplants per year are these: Iran, Malaysia, Taiwan, Thailand, Singapore, Hong Kong, Pakistan, and Vietnam. And there are some countries which do less than 100 transplants per year. And these are Philippines, Sri Lanka, Bangladesh, Nepal, Mongolia, Myanmar, Indonesia, and Uzbekistan. When we look at the Asia Pacific region, we can see that the number of allogenic transplants done every year is more than autologous transplant. This is just the reverse of what happens in the developed world, which will I come to. So approximately 20,000 or more allogenic transplants are done every year, and around 15,000 autologous transplants every year. There are far more match-related donor transplant done in the Asia Pacific region compared to unrelated donor transplant. And there's been a huge rise in haploidentical transplant, that means half-match transplant, in this part of the world. Now, this map tells us that how many countries are able to do more than 300 to 500 per 10 million population in each country in the Asia Pacific. It's hardly very few countries. Most countries in this region are able to do only 0.1 to 100 transplants per 10 million population. And this is much, much less than what each country requires. Now let us compare to what is in the West. The US registry, this is data from the US registry, the CIBMTR, where you see that the allogenic and autologous transplant every year are more than 20,000, more autologous transplant than allogenic transplant. Here, the match unrelated donor transplants are the maximum, followed by match related donor and haploidentical transplant. This is just the opposite of what we saw in the Asia Pacific region. And when we look at the European transplantation group, here again, autologous transplants are more than allogenic transplant. And here again, unrelated donor transplants are more than match-related transplant and haploidentical transplant. And the reason for that is that they have smaller family sizes, chances of finding a related donor are less, and there are large unrelated donor registries across the West for which they're able to find suitable donors for patients. Now, a little bit about the transplant evolution in India. In India, two extraordinary human beings have paved the way for transplantation in our country. Dr. Advani was the first to do transplant in the country in 1983 at the Tata Memorial Hospital. This was followed by Dr. Maman Chandy doing the first transplant at Vellore in 1986. This is the first transplant patient which was done in 1983 at Tata Memorial Hospital. Now we have shifted to ACTREC in Navi Mumbai, where we've been doing transplants for the last 15 years. In Vellore, from the old hospital, they've shifted to the new hospital for doing their transplantation in the last few years. Now, Indian Stem Cell Transplant Group has been an informal group from 2003. Now there is a formal society which has been formed in 2019, that is the Indian Society for Blood and Marrow Transplantation. Presently, by May 2026, we have 191 BMT units as member centers in this society. And the only important criteria to be a member is to be able to give their transplant data to this society every year. Now, this is our 2024 report. You can see in 1983, there was only one transplant center, that was Tata Memorial Hospital. By 2003, we only had 11 centers in the country. By 2013, we had 37 centers. And by 2025, we have 167 units. And in 2026 May, we have 191 units. However, it is not the number of units which is important. how many transplant units are doing how many transplants is important. Now, when you look at this bar graph, you can see that only 15 centers are doing more than 50 transplants per year in their centers. Most centers are doing less than 50. Many are only doing 10 transplants in the unit. This is not a good status. We should be able to have centers, more centers doing at least 50 to 100 in each unit, because that is what the country requires. Till 2024 December, 35,000 transplants have been done in India. Most of them, there are more allogenic transplants than autologous transplants in our country. And you can see that of all the transplants done, 60% have been allogenic, 40% have been autologous. Now, the haploidentical transplant, which have been the most challenging transplant, India has seen a remarkable rise in haploidentical transplant. That's the red bar in the last 5 years, and you can see that it is nearly equal to a fully match related donor transplant. And this is because even in India, the family sizes have come down. Finding a fully match related donor becomes difficult. Now, in India, acute myeloid leukemia is the most important, commonest indication for transplant, followed by hemoglobinopathies, followed by lymphoma and bone marrow failure syndrome. In allogenic transplant and in autologous transplant, multiple myeloma and the lymphomas are the foremost indication. Now, what is the current rate of transplant per 10 million population, which tells us how a country fares? Now, in India, it is 30 transplants per 10 million population. However, in the West, most of these developed countries do 300 transplants per 10 million population. So, if India has to compete with the West with more than 300 transplants per 10 million population, India needs to do around 40,000 transplants per year, and we do roughly around 4,000 transplants. So there's a huge gap. And why is the huge gap? Because the health expenditure in India is less in the health sector than in other parts of the world, and there is a direct proportion to the transplant rates in a country to the expenditure on health per capita by various government, and the out-of-pocket expenses in India is much more. Now, what is transplant density? There should be one transplant unit for per million population in a country. India is 0.12. If India has to have one transplant unit for 1 million population, then India should at least have 1,400 transplant units. Currently, we have 191. So there's a huge gap which needs to be covered. Now, when a transplant unit needs to be set up, it is important to understand that is there a need for it, and if there is a need, then it is best to start with the safest transplant, that is autologous transplant, and then go on to do the more complicated transplant. This is an excellent practical guide of how to establish a transplant unit in any center, and India itself has its ICMR guidelines for doing it. In Tata Memorial Center, we have done more than 1,500 transplants over many years, 1,200 transplants enacted from 2008 to 25, and the indications being myeloma and lymphoma and acute leukemia. Our 5-year survival rate is more than 60% overall survival, and the autologous transplant survivals are better than the allogenic because the transplant-related mortality is more for allogenic. And what we have done is now we have established transplant in other centers of TMC, which is in Varanasi, Vizag, Guwahati, and in New Chandigarh. So to end, there has been an exponential rise in number of transplant and centers in the recent years. However, more high volume centers are required for a region that comprises 55 to 60% of the world population. Access and affordability to transplant has increased. Acute leukemias, hemoglobinopathies, and bone marrow failure syndromes are the top 4 indication for allogenic transplant in this region of the world. Myeloma and lymphomas and neuroblastoma are the top 4 indications for auto transplant. These indications will refine over years in the era of modern therapeutics. Thank you for your attention, and I'm happy to take any questions.
Our next speaker, it is our honor to welcome Honorable Dr. Suyash Kulkarni.
It's really a wonderful feeling to be part of this program where I can connect with so many of our doctors from Africa. And I remember the warm days that we spent with some of the fellows who came here in radiology as well as intervention radiology for training. So coming to the topic, I will be giving an overview of area called as interventional radiology and its application in oncology. So this will move with this, right? So this is a prototype of an interventional radiologist. Like what I want to convey is that we are available always 24/7 whenever required, and with like a plumber, wherever there is a leakage, we are there, or wherever there is an obstruction, we are there. So we are plumbers working in the body. So wherever there is any hemorrhage, we always try to control it. And if there is an obstruction in the body, we try to release it. So in oncology, both these conditions are quite frequent and we are always available. So some of them call us interfering radiologists, but in the next 20 minutes, I will try to convince you that we are interventional radiologists. So the spectrum that we cover are non-vascular interventions and vascular interventions. So essentially, one of the commonly done procedure is a pictal insertion. Then various hepatobiliary obstructions can be relieved by procedures like percutaneous transhepatic biliary drainages. Then urological interventions like percutaneous nephrostomies and some ablative therapies. Among the vascular interventions, we do angiography, venography, embolization, angioplasty, and stenting. And whenever there is thrombotic occlusion, we try to relieve it by thrombolysis. So coming to the most commonly done and very important intervention in oncology setup, and that is a biopsy. Because everything in oncology depends on the biopsy. And what we need to do is a representative safe biopsy which can start the treatment. So usually in the oncology setup, whenever we get a patient like this, so this is a lady who had a lytic lesion in the spine, and as always in a malignant setup or in oncology setup, we think it might be a metastasis, and we planned an surgery or rather a biopsy for this patient. It's a difficult approach. We do such cases under CT scan guidance, and there are a lot of vessels over here. So we take a path in between thyroid and these major vessels, and we try to do the biopsy under CT scan guidance. And it is important that you have a good rapport with your pathologist, because after doing such difficult biopsy, the pathologist can very well say that this is a minuscule sample and you repeat the biopsy. So we need to have a good rapport with the pathologist so that you can get the diagnosis. And in this case, it turned out to be tuberculosis. So patient was very happy. Happiness, as we always say, is so relative that we used to feel bad when we used to get the diagnosis of tuberculosis. But in an oncology setup, getting a diagnosis of tuberculosis as against malignancy, the patient and the doctors are happy. So that is why biopsy is very important. Now, such critical biopsies like aortocaval nodes, we can again target under CT scan guidance. Some challenging areas, like for example, in the skull base, where there is a question whether this is a LCA or tuberculosis or lymphoma. In such cases, you can meticulously take a transoral or transnasal route and target those lesions at the skull base. And this patient came out to be a typical B-cell population lymphoma, and it's a potentially treatable condition. So we also take help of some hybrid imaging that we do. Like for example, here the lesion you cannot make out on CT scan, but with the help of PET-CT, we can exactly make out where is the metabolically active lesion, and we target it and get a representative sample. So overall, our bioimaging people have done this study, and the incremental value of hybrid imaging is almost 45% wherever it is FDG avid lesion. Sometimes patients' coagulation profile is deranged, and in such cases, we do the biopsies through transjugular access, where even if the patient bleeds in his own vascular system, and we can safely take a representative sample for such patients. Some modern ways of doing biopsies again is with fusion biopsy, where, for example, in prostate, you do not see the lesion clearly on ultrasound, but you see it on the MRI. So we fuse the images of MRI with ultrasound, and then we get fusion guided biopsies. So this is how we do it under now transperineal access, and you can see that under ultrasound and MRI guidance, multiple biopsies are taken, and they can be very much representative of what we want to see. Again, in breast nowadays, vacuum-assisted biopsy is something which gives a quite a representative sample, and this is the stereotactic kit for vacuum biopsy. And through the ultrasound guidance or mammography guidance, we do the biopsy and take a good representative sample, which helps us to diagnose the disease. So whenever we are doing biopsy, we need to, this is the overall statistics of various biopsies that we do, but it's important to keep an audit and see in your own setting, what is the sensitivity, specificity, and overall diagnostic accuracy of the biopsies that you are doing. And most important is that we are supposed to do the biopsies and not autopsy. So we can land up with situations like this after biopsy. This was a patient whose biopsy was done outside, and he came with to us with a throbbing swelling in the neck. And after doing an angiography, you can see that this is a pseudoaneurysm here, which is sitting like a bomb, and it can rupture anytime, and patient can die instantly. But at the same time, we should have the capability to manage such complications. The complications can be managed effectively and very under the guidance of, again, vascular interventions, where you just have to put a covered stent graft, and with these such dangerous conditions can be managed. But what is important is to have the setup to do such biopsies where you can also manage the complications. Another important, simple but important procedure is pigtail, because in the oncology setup, quite radical surgeries are being done. And after that, if there is pus collection, then the whole outcome of that surgery can get affected and patient can go in septicemia. So effective drainage of a collection is very important. And so, for example, again, such pigtails are used in draining urological obstruction like PCN, followed by this is the digest stenting to relieve the urological obstruction. Similarly, obstructions in the biliary system because of the tumors like peripancreatic or cholangiocarcinomas can be treated by procedures like biliary drainage, and then the obstruction can be relieved by various stents that can be temporary or permanent. A simple, also, I will just give an overview of the application of IR techniques in various systems. Like in GI system, a very simple but effective procedure is doing percutaneous gastrostomies, especially in patients with esophageal cancer or head neck cancer, where you cannot put an NJ tube. The patient's nutrition can be effectively managed by putting a simple percutaneous gastrostomy tube. Then coming to hepatocellular carcinoma, which is almost fifth common cause of death because of cancer. In such cases, there are various treatments like transarterial therapies to ablative therapies. And usually we are guided by the BCLC staging system, where in very early and intermediate stage of disease, the interventional treatment can be offered. So just to simplify it, in systemic chemotherapy, the chemotherapeutic agent goes throughout the body, and that is why along with its positive effect, we also get a lot of side effects. While in targeted or precise therapies, we go right into the organ or right into the tumor, and we can deliver high dose therapy without having any side effect on the rest of the body. So what we usually do is to go through the femoral artery and into the vascularity of the liver, and go selectively into the vascularity of the tumor and inject either chemotherapeutic or radioactive particles. So these are drug-eluting particles where they are soaked in chemotherapy, and then they are injected into the tumor vascularity, so that the high-dose chemotherapy can be delivered only into the target, and the systemic side effects can be avoided. So this is the angiography of liver, where you can see the tumor is quite vascular. Here we inject and with modern softwares, we can actually make out the supply to the tumor and go super selectively into that particular artery and inject the chemotherapeutic agent. This is how you see the chemotherapy is selectively going only into the tumor, and rest of the liver and other body parts are spared. The overall survival in our own setting in Tata Hospital for child A disease with hepatocellular carcinoma is almost more than 2 years. Coming to radioembolization, where the similar treatment is given, instead of chemotherapeutic particles, we inject radiotherapeutic particles. One of them is beta emitter, Yttrium-90 particles, which are injected through the angiography again. Like in chemoembolization, we block the blood supply to the tumor and cause ischemia and hope to kill the tumor. While in radioembolization, we do not block the supply, but the microspheres are injected into the tumor vascularity and they internally radiate the tumor, and we expect the tumor to shrink with that. So this is an example of a big tumor. After radioembolization, it has effectively become small as well as necrotic, and the portal vein has also got opened up. Another example of a big tumor treated with radioembolization, it has become completely necrotic. So the overall survival in various BCLC stages in a Tata hospital with radioembolization is almost 2 years in BCLC-B patients. And coming to one more way of treating tumors is that sometimes we need not open the patient every time. We can just put a small needle into the tumor and practically cook it. So this is called as ablation. So ablation has become an important modality of therapy where we use various energies like radio frequency, microwave, or cryoablation to treat the tumors. So what we essentially do is to put an electrode into the tumor and pass a very high frequency electric current, which causes movement of the tumor particles and creates thermal energy that is spread by convection and conduction and causes thermal coagulative necrosis of the tumor. So this is the setup where we have these generators of radio frequency ablation and various electrodes that we use for ablation. For example, this is the hepatocellular carcinoma, typically hyper enhancing and washout of the lesion in liver. We put an electrode under CT scan guidance. You can see that it is beautifully ablated along with a margin like a surgical margin. So you need not operate this patient. You just put one small needle and the patient can go home the same day or the next day. So the complications are less, morbidity is less, and patient can get back to the work quickly. So this is how we follow these patients along with MRI. You can see that the lesion is completely necrosed. The overall survival with radiofrequency ablation in our own data is almost 65% 3-year survival for these patients. Another modality is microwave, like the same microwave that we use in our kitchen. As we cook our food, we cook our tumors over here. We put that microwave antenna inside and just burn it out. Like for example, this is the FDG avid colorectal metastasis. You just put small microwave antenna, and then you can see that it is completely ablated. A procedure which can be done on a daycare basis or a one-day admission process. Coming to some sophisticated softwares which we practically use to plan the hepatic surgery. Like here you can see that we can do the segmentation of the tumor, and the functional liver residue is calculated with this software. And whenever it is less than 25%, we need to do a procedure called as portal vein embolization. Like if you have to remove the right side of the tumor, you do the embolization of right-sided portal vein. The left liver gets sufficiently hypertrophied, and then you can safely operate this patient. Coming to thoracic system, we can similarly ablate various tumors in the lung, like those in the early stage or those who are having relapse after radiotherapy or those involving the chest wall. These are the tumors which can be effectively ablated with radiofrequency ablation. For example, this small tumor under CT scan, you just put one radiofrequency ablation, and you can see that with this, the tumor is completely treated. This is how the tumor becomes cavitated or shrunk after radiofrequency ablation. This is the follow-up. And another patient of fibromatosis, a young lady came with a big fibromatosis of the chest wall. After 5 sessions of radiofrequency ablation, it has completely got treated. And she had developed suicidal tendency because of this tumor. Now she is happily living without any morbidity. So some vascular lesions this is a patient of leukemia, completely treated, but after on follow-up he presented with hemoptysis because of the pseudoaneurysm or blowout of the subclavian artery. The treatment is simple. You just put a covered stent graft and it can be taken care of. So patients sometimes after chemotherapy, they get immunocompromised and develop fungal infections. You can see this aorta got invaded because of fungal infection, and this patient had an aortic aneurysm. You just put a stent graft and it can be treated without opening the patient. An important condition in oncology, these patients are quite vulnerable to pulmonary embolism, which can instantly be life-threatening. We need to put such filters in the IVC, which will prevent the any thrombus going to the lung, and the pulmonary embolism can be prevented. This patient, she presented to us with total ophthalmoplegia and epistaxis. She was again a treated case of leukemia. She had developed fungal pneumonia and invasive kind of aspergillosis, which had eroded her carotid artery. And on angiography, we can see that this is almost going to rupture kind of aneurysm. The treatment is again simple. You just block this carotid artery, and patient ophthalmoplegia as well as epistaxis was taken care of. Now, embolization is an important procedure which we use, especially in musculoskeletal tumors or the tumors which are very vascular. In such cases, for example, this is a tumor which is quite vascular. To operate that tumor can cause significant blood loss. To do an angiography and block the blood supply so that the surgeon can get a completely blood-free or bleeding-free bed, and the tumor can be completely operated. This is an example of angiofibroma, which are very vascular tumors. This we do an angiography and we directly inject embolizing agent. You can see that it is completely embolized, and this tumor is completely removed with a minimal blood loss of 500 ml. Otherwise, they can bleed up to 20-25 liters as well. So these are quite effective. Sometimes the bone tumors, like this is a tumor of the sacrum, a chordoma. Surgery will be very morbid in such condition. So what we do an angiography. It's quite an vascular tumor, block the blood supply, and then with serial embolization we can effectively treat such conditions. Another important or very common but a very painful condition is a tumor called as osteoid in the bone, and it usually affects young children, affect their growth, affect their studies, and are very painful. The treatment is simple: put the needle, radiofrequency ablation, a 5-minute protocol, and it is completely treated. So this another young patient was being treated as TB, tuberculosis, and he was bedridden. While the visual analog score was 8, but on MRI we could make out that it is osteoid and of the end plate of the vertebra, treated with radiofrequency ablation, and it is completely treated. The patient started going back to the college. Osteoblastoma, again a difficult area of C6 vertebra. You can see that it is quite active on the PET CT, and after treatment it has become completely photopenic. Surgery in such situations can be quite morbid, but with a small needle and a 5-minute protocol, we can effectively treat these patients. Coming to the role of intervention radiology in pain management, various procedures like sclerotherapies, vertebroplasties, or osteoplasties can be offered. For example, this is an aneurysmal bone cyst of acetabulum, which is operating it can be quite morbid, but just put sclerosant under CT scan guidance, and this condition can be treated. Hemangiomas of vertebra, again a very painful condition. What we do in such condition is we do sclerotherapy and we do angiography. But on angiography, you can see there is an artery, which is a very small artery, and if we embolize it, the patient can land up with paraplegia. So in such conditions, what we do, we inject sclerosant and we inject cement into that, so that patient can be completely pain-free, and hemangioma can be treated. But it's not always easy. For example, C2 vertebra lesion, quite painful lesion. In such cases, you take a transoral access, and these patients can be treated with vertebroplasties. So this is how the cement is injected, through transoral access. Renal cell carcinoma, usually these patients that land up with painful metastasis. You do the ablation and put cement, and we can practically reconstruct the pelvis over here. So again, in sacrum, if there are lesions in the sacrum, we can inject under CT scan guidance and do sacroplasty, so that patients can be relieved of the pain. These are all palliative procedures, but for the patient, they are quite painful and can be effectively managed by a small needle and cement injection. Coming to the urological procedures, in urology, nephro, especially in the kidneys, we have renal cell carcinomas. You can see that a small a renal cell carcinoma up to 3.5 centimeter. Nowadays, you need not operate these patients. It has been proven with randomized control trial that partial nephrectomy has got same result as radiofrequency ablation. You just put a needle and burn it out, and you can see that the tumor can be completely treated with equal results as surgery. So some complex cases like in after the surgeries in oncology, some patients they develop chylous effusion, and these are difficult to treat. In such cases, what we do lymphangiography. This is a lymphangiogram. The lipiodol is injected in that, and then we try to find out where is the leak. You can see that in this patient, the lymph is leaking over here. In such cases, what we do is we directly puncture the chylus, cisterna chyli, and embolize the cisterna chyli or thoracic duct, and the lymphatic leak can be stopped. You can see that this patient who had a chylous effusion over a period of time as the lymphatic lesion after embolization has become completely clear. So these are quite difficult cases, but with IR techniques, we can treat them effectively. Coming to some palliative conditions like the SVC or IVC obstruction, these patients, they develop a lot of edema over the face and limbs. You just put one small stent over here and they can be relieved of their obstruction. Pediatric patients like this, they sometimes they present. These are the conditions which they behave like tumors, complex vasculoproliferative neoplasms. And these patients started bleeding because of consumptive coagulopathy called as Kasabach-Merritt syndrome. And what we do is that we just put sclerosant, and this patient can be effectively treated with few small needle punctures where we inject the sclerosant in between. While such patients, they have got such ghastly lesions, which are nothing but on MRI, you can see that there is a lymphocele, and you just put a small needle and sclerotherapy, and they can be effectively treated. And these patients, now this was also removed, and this patient was completely treated just by small needle puncture. Coming to the last condition that we treat, the retinoblastomas, which are the young children, and these are somehow those unfortunate children who develop tumors in their eyes, and we have to remove their eyeball if we have to save their life. And in such cases, what we do is that because the other options for treatment are either you do systemic chemotherapy or radiotherapy or enucleation, and all these therapies, they have their own side effects. But in such cases, especially in India, whenever we talk about enucleation and in female child, the family doesn't come back, and when they come back, the disease already progressed and we cannot save the child. In such cases, what we do an angiography, cannulate the ophthalmic artery, and do angiography and inject the chemotherapy into the blood supply of that eyeball itself, and we can effectively cure these children. For example, this is a 4-month-old baby with a tumor in the eye, and with after 2 sessions of therapy, the tumor has been completely treated. This was the bulky tumor. After 2 sessions, it is completely treated. You can see that this is the tumor on B scan. After 2 sessions, it has got completely got treated. So overall, in our in Tata Hospital, we can save almost 75% eyeballs of the children who have got the intraorbital tumor, and without any significant complication. So this was and this sometimes it is hereditary, and sometimes they develop tumor in both the eyes. Like this father was treated 25 years back in Tata Hospital. The child also developed a similar tumor. One eye was removed, and another eye, the child came to us for treatment. But because it was involving the optic disc, we had to take out both the eyes of the child. So it's not that always we become successful. There is a long way to go, but we can offer many effective therapies with interventional technique. So that is what I wanted to share with you all. Thank you very much.
Our next speaker for the session is, we'd like to invite Honorable Professor Dr. Siddhartha Laskar.
Thank you very much, and very good evening to everyone across the globe, wherever you are. I'll spend the next 15 minutes to 20 minutes just telling you about the use of radiotherapy for pediatric malignancies. As you know, we come from this famed institution, started off in Mumbai and now spread across the country in 10 institutions across the country. And in all, we treat about 130,000 new cancer patients every year. Coming to pediatric tumors, the definition of pediatric tumors in most part of the globe would be children who are less than or equal to 19 years of age. So if you look at the number of children who are afflicted with cancer in our country, it's about 75 to 80,000 children are affected with cancer every year. And this incidence is pretty similar to what you see in Africa and in this region, with a slightly higher incidence seen in North America and Australia and some parts of Europe. But the important thing is to see what is the difference in the outcomes of these children who are affected with cancer. Now, if you look at the two graphs here, in Africa, there's a large number of children who have cancer, but they are not categorized into a particular kind of neoplasm. But if you look at the remaining diagnoses across the globe, the commonest tumor that you see would be acute lymphoblastic leukemias. And this is followed by brain tumors that you can see in orange. This is pretty similar across the globe, except in Africa, where the other tumors actually predominant, like acute lymphoblastic leukemias and the unclassified tumors. This is the slide that I want you to really concentrate on. If you look at the incidence or the new cases of cancer that you see in Africa and Asia, they are pretty similar to what you see in America or Europe. But the difference comes in the outcomes. On the right-hand side of your graph or of your slide, you can see that there are two lines that they go up. And these are for Africa and Southeast Asia. So that means a large proportion of these patients or children who are diagnosed with cancer in the low and middle income countries have greater mortalities compared to high income countries. And on the right side of the slide, you can see that the cure rates in high income countries is about 80%, whereas in the low income countries, it's about 20%. So it is very important for us to actually do strategies by which we can improve outcomes. Now, this is a relatively old slide, which I have borrowed from my colleagues from the famed St. Jude Children's Hospital in Memphis in US, where I had trained for some time. And if you look at the outcomes of diseases that they would have treated earlier in St. Jude, if you see that leukemia in 60s, they cured about 50%. And similarly, retinoblastoma, 75%, and Wilms tumor, 50%, osteosarcomas, 30%. But then, with the improvement in techniques and methods of treatment, they report outcomes of 90% and above. And that is what we need to achieve. And we need to develop strategies by which we could actually match and get closer to these numbers for our children who are diagnosed with cancer. So coming to the role of radiotherapy in childhood cancers, there are multiple diseases or multiple cancer types in children in which radiotherapy has been used. In Hodgkin's lymphomas, for early stages, more than 90% of them would have received radiotherapy. That has changed over a period of time. In nasopharyngeal cancers, almost all 100% of patients would receive radiotherapy. A large proportion of CNS tumors would receive radiation. A significant proportion of bone tumors like Ewing sarcomas and osteosarcomas and other bone tumors, one would receive radiotherapy. And again, in neuroblastomas and retinoblastomas, it would depend on the type of and the stage of disease that you're dealing with. In the interest of time, I will just touch upon a few of those diseases where radiotherapy is used. Now, coming to Hodgkin's lymphoma. Now, Hodgkin's lymphoma is very, very sensitive to radiotherapy. If you give radiation therapy, the tumors just melt off. Now, if you can see these data from the 1950s, from Vera Peters from Ontario Institute of Radiotherapy, with the high doses of radiation that were used at that time, the 10-year survival rates were close to 80%, which is very good. Similarly, there were reports from Stanford University where Henry Kaplan used large field radiotherapy to high doses, and the 10-year progression-free survival reported was about 80%. So here we are, we have outcomes of 80% and above. So that seems to be the best treatment that is possible. But the problem with these treatments were that they were associated with adverse effects. It affected heart, it affected growth, it affected hormones, it caused infertility, and many of these children who actually lived for a long time, they developed second cancers in the form of breast cancer, lung cancer, esophageal cancer, myelodysplasia, and leukemias. And so the current research now globally is to optimize the combination of chemotherapy and radiation therapy. The intent is to combine these two modalities in the best possible way that the toxicities of treatment reduce while you optimize the control of disease. And this is another article from that time which showed that the disease control would be very good with radiation therapy, but you would end up with complications. And thus, now there are studies like these, and this one was published by the German Pediatric Oncology Group, where they classified children into risk groups. The low risk, which is stage 1 and 2, the intermediate risk, which is 2B, 3A, and the high risk, which is 3B and bulky disease. And then when they looked at the outcomes showed that in patients who had bulky disease or extensive disease or residual disease, the use of radiation therapy improved outcomes. Whereas for the low-risk disease, the current treatment would be to avoid radiation therapy and treat with chemotherapy alone so that the complications are reduced in the future. Now, we did also do our study from our own institution, and this was published in the Journal of Clinical Oncology in 2004. This was a randomized clinical trial where we looked at the role of radiation therapy in patients who receive or achieve a complete remission after the chemotherapy. And then we reported that in young people also with bulky disease or residual disease, the addition of radiation therapy improved outcomes. And this applies to situations where you cannot use aggressive chemotherapy. So it is globally applicable, and that is one of the reasons why I actually wanted to show you this. Radiation therapy has changed over a period of time. We used to treat large fields, large areas of the body would be exposed to radiation. It used to be called total nodal radiation in 1962. And currently, we do involved site radiation therapy, where we treat only a small volume. And because of that, the disease control remains the same or better, but there's a significant reduction in the possible acute or late side effects of radiotherapy. We have benefited with new technologies. This is one example where the patient had a mediastinal disease, and we know that giving radiation therapy to the mediastinum involves the heart, lung, thyroid, and so on. And if you use technologies like breath hold techniques, you would be able to reduce the volume of lung and heart that comes into the radiation field, reducing the chances of complication in the future. With technologies that we have now, and one of them is proton beam therapy, you can see how beautifully you are able to spare the heart and lungs from the beam of radiation and thereby reducing the chances of complications. Now, moving on to nasopharyngeal carcinomas. These tumors, you would have seen this slide earlier when Dr. Sarbani showed you. Nasopharyngeal carcinomas are treated with a combination of chemotherapy and radiation remaining the mainstay of treatment. And in order to cure these diseases, you need to deliver a high dose of radiation in the range of 66 to 70 gray. And because of the proximity of the tumor to critical structures like the brainstem, the eyeball, the optic nerve, it is essential that you use advanced conformal techniques by which you can reduce the chances of complication. So we in our institution, when we got intensity modulated radiation therapy in 2003, we started using them IMRT for nasopharyngeal cancers, and we compared the difference in outcomes. And we found that we were able to spare the spinal cord, the brainstem, the parotid gland very better than what we could do. And we've published our outcomes. And this was reported as one of the first studies to actually address this issue about the ability to reduce the complications in treating nasopharyngeal carcinomas with radiotherapy. And this evidence was being used globally to advocate the use of radiotherapy in nasopharyngeal carcinomas in children. Moving on to bone tumors, Ewing sarcoma is one of the commonest bone tumors in the second decade of life. It affects almost the entire skeleton, but the majority of it would involve the pelvis and the centroaxial skeleton. And the median age is about 14 years. Radiation therapy is again very, very effective as a local control modality for Ewing sarcoma. As you can see from this publication that came in 1953, this is long, long back, but even at that time, the local control rates with radiation 70%. But there was a problem. The problem was that there was disease that would come back, and that's why proved 5-year survival was 14%. So the standard treatment now is a combination of chemotherapy, surgery, and radiation therapy. And I call this tumor the best example of combined modality management. There is no single modality that can cure this disease, but with a combination of chemotherapy, surgery, and therapy, one could get the best outcomes. So where do we use radiotherapy in Ewing sarcoma? In patients that are operable, where surgery could lead to a lot of morbidity, or in cases where you are not able to resect the disease completely. And in post-operative situations where the surgical margins are positive or closed, where there's a pathological fracture, or if there is a contamination of tissue around the tumor, those are the situations where we use post-operatively radiation therapy. Now, this is an example of a patient who had Ewing sarcoma of the iliac bone. Obviously, this was not operable, but this was very large in size. So to cure this disease, we have to deliver a high dose of radiation, and that is associated with complications in the associated bladder. So we studied to see if increasing the dose of radiation does improve outcomes. And this is actually the only randomized clinical trial globally available today to address this question of whether the increase in dose of radiation therapy for inoperable Ewing sarcoma improves outcome. And as you can see on your left, the outcomes with escalated doses of radiation improved from 59% to 76% at 5 years. Now, another example of innovation. Now, that car is not for advertisement, but that is just to show that in situations where you have to do limb salvage, prosthetic replacement is one of the tools that is available. But at times, the cost of the prosthesis is prohibitive. And in this case, it was actually more than the cost of the vehicle on which it is kept. For this, we, along with our colleagues from surgery, and you're going to hear Dr. Ajay Puri in the next presentation, we combined and we did this technique called extracorporeal radiation therapy. And with this kind of a technique, we resect the bone out, radiate it, and put the same bone back into the patient. And this is the outcomes. This is early results that we had published in 2012. We have a larger series currently. The outcomes oncologically was very good. We did not have failures within the bone with 1 fraction of 50 gray, and the functional outcome was also very good. For chest wall tumors like this, it is very challenging to deliver radiation therapy. So you need expertise and equipment to deliver the right dose of radiation in the right way so that you have the best disease control. And these are our outcomes of local control of about 67 to 70%, and we have improved outcomes currently. For osteosarcomas, chordomas, and chondrosarcomas, these are radio-resistant tumors, and generally they are located in places where it is difficult to do a surgical resection. And in those situations, it is highly challenging to deliver the dose of radiation optimally so that we not only achieve disease control, but also are able to avoid complications. Now, what our protocol was, We deliver a very high dose of 72 gray in 40 fractions using conformal radiation therapy. This is our own data of chordoma, osteosarcoma, and chondrosarcoma, and we were able to achieve disease control of 75% in these patients. Coming to proton therapy, which is where the new kid in block, and Dr. Sarbani did mention a little bit about the advantage of proton and the ability to spare normal tissues. As you can see globally from the European data, a large number of chordomas, chondrosarcomas, rhabdomyosarcomas, Ewing sarcomas all benefit with proton therapy. And this is a benefit of proton therapy. On your left-hand side, you can see that orbital tumor with conventional radiation, you end up giving a little bit of more radiation to the opposite orbit. But whereas with protons, the opposite orbit is literally completely spared of the proton of the radiation dose. So I was part of this consensus report for proton therapy that we published from Stockholm. And we did again show from this that for tumors like chordomas, rhabdomyosarcomas, neuroblastomas, lymphomas, and Wilms tumor, there is a significant role of proton therapy. And we are privileged at Tata Memorial Hospital, Tata Memorial Center, that we have a 3-gantry proton system that is functioning since August 2023. And we've treated more than 1,000 patients till now, and the results have been very good. The last part of my talk is to do with brachytherapy, which is very dear to me. And what do? We remove the tumor, we insert stainless steel needles and brachytherapy catheters and into the tumor bed. And we do a dosimetry like this. This is a young kid with a thigh soft tissue sarcoma, and we deliver the dose. Now, again, this is a small child with a soft tissue sarcoma on the arm. If we did any kind of external radiation, it would have affected the bone growth in a significant way. We were able to do brachytherapy. Another young child, just about a few months old, surgical excision done, high-grade sarcoma, wouldn't have been able to spare the bone with external beam radiation. We did brachytherapy, and this is the kind of functional outcome that you can see. He's a grown-up boy now. You can see that kid who's sitting on my OPD table. This is what he looks like now, and with excellent functional outcomes. So we looked at our outcomes. We had local controls of 80% and above at the end of 5 years and 6 years. With that encouraged outcomes, we have explored other areas. Like this is a PNET that required radiation in a young child. We did brachytherapy with very little side effects on the child's function. This is the child after that, and this is the functional outcome. So it's not moving, but I'll move on. And that's him shaking hands with me. With plastic reconstruction, again, very good functional outcome with brachytherapy. And I'll finish with this last one. This kid was very tiny, had a rhabdomyosarcoma of the orbit. You can see the tumor here. We gave chemotherapy. Any kind of surgical intervention or radiotherapy with external beam would have affected the eyes and the vision of this child. We did interstitial brachytherapy, inserting needles into the orbit. And this is how we did it. That's me doing this procedure. And this young child, this is another child where we did the same kind of procedure. You can see this child with these brachytherapy catheters in, highly conformal radiation to the tumor, sparing the eyes. This is the kind of comparison that we did. And this is the functional outcome that you had for the child So it's a very, very useful tool for brachytherapy, very useful for all sites in children, especially. And this is a more recent outcome. At 10 years, our local controls were 80% and above. So we are very, very happy with our brachytherapy program, especially for children. And so to summarize and conclude, radiation therapy is a vital component in the multimodality management of pediatric tumors. This needs to be done in specialized centers with trained manpower. You need to have appropriate knowledge and appropriately customize your treatment using more modern equipment and modern techniques. And it is a combined team effort of chemotherapy, surgery, radiation, nutritionists, rehabilitation specialists, supportive care, palliative care, and finally, judicious use of radiotherapy for children actually results in excellent outcomes. With that, I will stop and thank you very much once again for the opportunity. Thank you.
We would like to invite our next speaker, Honorable Professor Dr. Maya Prasad.
Thank you very much, everyone. And I think I've been listening to the talk so far, and I think it's been a very good session so far. So I'm a pediatric oncologist at the Tata Memorial Center in Mumbai, and I'm very happy to be talking about one of the most common pediatric cancers, which is Wilms tumor, and specifically about how we can try and achieve optimal cure in low resource settings. So Wilms tumor is the most common primary malignant kidney tumor in childhood, and it constitutes around 5% of all pediatric malignancies, which in itself is quite rare because children's cancers are quite rare. And 10% of these may be associated with congenital predisposition syndromes. So this is a graph which a lot of you may see about how good the outcomes are in pediatric cancers. Dr. Lashkar also showed us this. And in the Western world, over 90% of children with Wilms tumor go on to have long-term survival. The treatment of Wilms tumor is very special in that it requires a large and a multidisciplinary team to actually make the treatment work very well. So not only do we need people who do chemotherapy, surgery, and radiation, but we also require a radiologist and a pathologist as integral parts of the team. So there's been a lot of developments in the treatment of Wilms tumor, and it's very important to know how it came about because both the risk stratification of Wilms tumor has evolved over time, and treatment is now best done according to the risk category of the tumor. So there are two main groups which have been working on Wilms tumor, and one is the Children's Oncology group or from the North American group, and the SIOP group or the European group. So in both of these groups, stage as well as histology have been considered to be the key factors in risk stratification. In the North American group, age, tumor weight, rapidity of the lung nodule response, and certain molecular factors have been factored in. Whereas in the SIOP protocol, the tumor volume, the responsiveness to initial chemotherapy, certain histologies, and again, molecular factors have been incorporated into the risk stratification. So stage is very simple. It is very much like most of the other staging where stages are from 1 to 4, depending on the extent of the disease, with stage 4 being metastatic disease. And interestingly, here there is a stage 5 as well in Wilms tumor. And stage 5 refers to bilateral Wilms tumor. There's, as I mentioned earlier, histology is a very important component of risk stratification. And here again, the two groups have given different kind of classifications. So very broadly speaking, anaplasia or which is actually a poor prognostic factor across all tumors, adult and pediatric, is also prognostically important in Wilms tumor. So anaplasia in Wilms tumor generally portends that it is a high risk. In the SIOP stratification, there's also something known as blastomal type of Wilms tumor, and we'll come to that later and why that's important. So it's important here in Wilms tumor in the SIOP classification because in the SIOP treatment protocol, we usually give chemotherapy first, and then we do the surgery. And once we do the surgery, after giving chemotherapy, we normally expect that most of the active tumor is gone. But if the blastomal component or the active and primitive embryonal kind of cells persist, even after giving chemotherapy, it indicates that the tumor is not responsive to chemotherapy. That's the reason that this blastomal type histology is important. So the evolution of treatment has been very interesting, and the treatment of Wilms tumor has come a long way from the initial decades, where surgery alone was the treatment that was given, followed by surgery plus radiotherapy. And once chemotherapy started becoming available, chemotherapy was introduced. And it's very, very interesting to know that from the 1960s to the 2020s, over the past 60 years, it's the same 3 drugs, which are dactinomycin, vincristine, and doxorubicin, which continue to be the main chemotherapy drugs which are used. But we can see that with the evolution of treatment, the outcomes have also really drastically increased over the years, and they continue to be high if children are treated appropriately. Surgery is very crucial. It is the cornerstone of treatment in Wilms tumor, and generally we need to remove the entire kidney. So it's radical nephrectomy and lymph node sampling. Very important. There are at least 7, depending on which protocol you follow, 5 to 7 stations of lymph nodes need to be sampled. The tumor needs to be ruptured, the tumor needs to be removed completely and without rupture. And the lymph nodes need to be sampled even if there's nothing visible on the radiology. There are lots and lots of developments in surgery, including in children with bilateral Wilms tumor, where there is an increasing use of nephron-sparing surgery. And also recently, in very small tumors, we can conserve the kidney. We don't need to remove the entire kidney. We can just remove the tumor. But these are all to be done only by experts, and it's very important to have expertise in the surgery of Wilms tumor. Chemotherapy, as I mentioned, is very important. It's extremely chemosensitive, and the same 3 drugs, that is vincristine, dactinomycin, and doxorubicin, continue to be the main drugs which are used. But depending on the histology and other important factors, we may consider the addition of other chemotherapy drugs. Radiation is very important in certain kinds of Wilms tumor, especially in metastatic Wilms tumor and in high-risk pathological features. So the improvement in Wilms tumor treatment has not been simple. It's come as a result of multiple studies which have been conducted by both the North American group as well as the SIOP group. So several studies which have been conducted over several years or maybe several decades as well. So the North American protocol and the SIOP protocol differ very much by concept, because in the North American or the COG protocol, it usually starts with surgery and then we go on to chemotherapy, and depending on the indication, we would give radiation. Whereas in the SIOP protocol, invariably we start with chemotherapy first and then we go on to surgery, followed by chemotherapy after that, and radiation where indicated. But which is the better approach? We really don't know, because a lot of studies have given a lot of results, but almost everything is comparable. But there are certain advantages for both of these approaches. So if we do the COG approach, which is nephrectomy first, it allows for early and accurate histological diagnosis because we have the tumor sample in hand. We are able to collect the biological materials. Nowadays, it's becoming more and more important to have biological materials for molecular studies. And if we get that upfront before we start treatment, it probably has an advantage. Staging information such as all the presence of tumor spill, etc., even before chemotherapy starts, may be quite important. But coming on the other hand, the approach of giving chemotherapy and then doing surgery definitely has a lot of advantages, especially for those of us who are in countries where the expertise may not be as much. So if we are able to give chemotherapy first, these children who present with these very large tumors generally have fewer tumor spills. The vascularity and the size of the tumor decrease, so the chance of rupture or tumor spills is much less. So tumor spill or rupture actually makes the tumor stage 3. And once this tumor becomes stage 3, we need to give radiation, and we also need to give additional chemotherapy. So if you give neoadjuvant chemotherapy followed by surgery, there is a less chance of developing stage 3 tumor. So fewer children will have to receive the third drug of doxorubicin, and fewer children will also need to receive radiation. So that's very important, especially because these children are very small children who may develop a lot of toxicities with additional and unnecessary treatment. So there are 2 things about risk stratification. One is that if you are able to risk stratify correctly, you can actually decrease the treatment that is required to be given. On the other hand, if it's a very high-risk tumor, you can even increase the treatment that has been given. So if you give more treatment in high-risk pathology, it generally improves the outcomes, but still it may not improve the outcomes as much as compared to low or intermediate risk. So high-risk tumors generally continue to do poorly despite increasing the treatment. One very important development that's happened over the past 20 years or so has been the recognition of molecular features in Wilms tumor. So these are the loss of heterozygosity of 1p and 16q, as well as 1q gain. I'm not going into such great detail about these, but with the recognition of these features, the risk stratification has been even more fine-tuned, and the treatment has been escalated even on the basis of these molecular features. So not only on the basis of higher stage and worse histology, but also on the basis of adverse molecular features, there has been an increase in the treatment that's been given. And in this, it's quite encouraging to see that children who are treated with increased treatment in these high-risk molecular biology tumors, in fact, continue to do better than without increasing treatment. So this is the importance of knowing about the molecular risk stratification. The PSYOP protocol is something that I would like to focus on a little bit more, because I think that's what is followed more in lower resource settings. So as I mentioned earlier, we first stage the tumor. We do the radiology first. We find what is the stage of the tumor. And depending on the stage of the tumor, we start the patient on neoadjuvant chemotherapy. So in stages 1 to 3, it is only 2 drugs which are started with, actinomycin D and vincristine. And these are given for 4 weeks. At the end of 4 weeks, we do another scan and then proceed with surgery. If it's a stage 4 or a metastatic tumor, we give 3 drugs, that is vincristine, actinomycin D, and doxorubicin for 6 weeks. Again, the child is reassessed, and then we go ahead with surgery. So once surgery is done, we then again risk stratify the patient based on the histology as well as the staging which happened after the surgery. And based on that, they could be either low risk, intermediate risk, or high risk. And as you can see here, the treatment differs considerably depending on the risk stratification post-chemotherapy, post-chemotherapy and post-surgery. So the umbrella study, which is the latest study which has been done by PSYOP, has also incorporated the molecular factors into this study. This is also very similar to the previous protocol of the PSYOP 2001 that I showed, but I will not be focusing too much on this. Bilateral Wilms tumor is extremely challenging because children have extensive disease. Sometimes their underlying kidneys also may be abnormal. So it's a very highly challenging disease to treat. So overall, Wilms tumor has an excellent prognosis. It requires multidisciplinary management. Stage and histology are key prognostic factors, with molecular markers being of increasing importance. But let me come to the second part of my talk, which I think is probably more important. It is that there is very, very stark disparity in the outcomes of children with Wilms tumor treated across the world. We all know that most children's cancers are concentrated in South Asia, South America, and Africa, where 80% of the children with cancer live, but only 20% of these children, in fact, survive. So all that I spoke about, is that applicable to low resource settings? It is possible, at least to a certain extent. Molecular risk stratification may be out of reach, but definitely we can bank on stage as well as histology, as well as following the standard of care approaches. Very importantly, there's a higher burden of toxicity, both early as well as late. So it's very important to identify what are the relevant prognostic factors in each setting. Children in Africa and in India generally present with large tumors. So tumor volume is a very important prognostic factor in these settings. And when you give chemotherapy and reassess after the chemotherapy for surgery, even the post-chemotherapy tumor volume is a prognostic indicator. The nutritional status is very important, and there's been a lot of papers, especially from Africa, which have found that if you, in fact, assess the children's nutritional status very well, and then go ahead with appropriate intervention, it may in fact increase the outcomes of these children. I'm sure most of the people who do pediatric oncology know about the WHO's Global Initiative for Childhood Cancer. Wilms tumor is considered to be one of the 6 important cancers in this because it's a highly curable tumor, provided all the systems are set in place and multidisciplinary care is available. I would also like to mention the new guidelines that are available from St. Jude Children's Hospital, from PSYOP, PROS, and many other groups which are involved in the treatment of children with cancer. And this is available at this website, which is called ARIA, ARIA. And now they've made a few guidelines, but Wilms tumor guidelines will also be available soon. And these are meant to be given according to they are resource adapted guidelines. So these come, you have to put in your specific scenario and it will help, it will guide you as to how to provide the appropriate treatment for your patient. There's also CanCare Africa, which I'm sure many of you know about. It is an Africa-wide project which was trying to look at improving the outcomes in children with Wilms tumor in Africa, and they found that patients present late with large tumors, there's a high proportion of metastatic disease. Many children are acutely malnourished. There's a risk of neutropenia, lots of treatment abandonment, but also that treatment abandonment may be preventable, high treatment-related mortality, and poor access to radiotherapy. So a lot of issues, and this protocol has also focused on doing supportive care in the form of infection management, nutritional support, blood component transfusions, pain control, and prevention of abandonment. All of this has been published in a series of papers which has come out over the past 3 or 4 years. So these are all excellent papers, and whoever is interested should please read these. So in a resource limited setting, what matters the most? Of course, we know that early diagnosis and timely referral is key. The use of standardized and resource adapted treatment protocols is extremely useful rather than blindly copying protocols which may not be useful for us. Safe surgery by trained teams, accurate pathology and staging, access to radiotherapy, and reliable availability of essential chemotherapy and supportive care. Prevention of treatment abandonment in this highly curable cancer is also very important. So it's apart from all of these, we need to collaborate. We need to have our data systems in place, and we need to do research and innovation even in resource limited settings to try and find out what is best in our setting. So definitely cure is achievable in children with Wilms tumor in any setting, but I think for the optimal cure of our children with this highly curable disease, we all need to work together. So thank you very much. And I'm not sure if there's time for questions, but maybe I could take questions if they're in the chat. Thank you.
We would like to welcome Honorable Dr. Jaita Theodore.
Thank you very much. Very good evening to everyone. It's been a long day, but I think that the light is at the end of the tunnel. And I am here to talk about palliative care. And you would have seen in most seminars, conferences, talks, we talk about early integration, but we are always the last. So the day when we come in sort of mid-level, I think that is when we have made our marks, but we are still going to talk about it. So, I think most of us know what the palliative care definition is. What do we mean basically is that apart from the disease that the person is having, in which in our case we are talking about cancer, we also have to take the person who is having the disease, and not just the person, also the family and the community around him or her. So the WHO started with a good definition, but you can see that it has been redefined recently. And what we want to talk about is that it's not just the disease, it is the disease related suffering, which can be quite serious, and that is what is called as serious health related suffering. And we know, because we are talking about the person, it is not just the physical. We have our social, our spiritual, our emotional functioning, and that if we do not take care of this, there would be a high risk of mortality negatively impacting palliative care. So these are the ingredients of palliative care, which should be actually through the illness trajectory. There has to be a lot has changed, and we always had earlier that palliative care would come in later when nothing could be done for the disease, but now we know better, and that it has to be through illness trajectory. Because of the nature of what we are doing, it is comprehensive. The patient is at the center. And how do we do it? Apart from symptom management, a lot is involved in communication and goals of care discussion, which will lead to improvement in symptoms and quality of life. And of course, that has to include caregivers. And this is a very important diagram, which I must stress on, that you can see that the palliative care, now those are the components, but within the components is end of life care, and within the end of life care component is terminal care. So a lot of misinformation is there, that palliative care is only end of life care, or palliative care is only terminal care or hospice care. But I think you can see from the diagram that it is much more than that. And you can see from this diagram as well that it is concurrent with ongoing treatment. And why do we need it? Because we know through the illness trajectory, there would be things happening like, in the beginning, we want sort of disease containment, but then there could be decompensation, there would be dependency, there's maybe a gradual decline, and that is when the transition takes place, and this is why the need of palliative care. So why and how and when should we integrate palliative care for this particular patient? You can see she is a 63-year-old lady from here. She's North India, but she could be anywhere in Asia and Africa. She has an adenocarcinoma. With Merck's 2023, she was diagnosed, and she's been having these symptoms of loss of weight, cough, breathlessness. Various investigations have been done. All the markers have been done. She has been prescribed osimertinib, and she's been taking it at local place. She lives with her husband and 2 sons. They go back for that they go back to the treatment plan, but they come back here because we are the primary center. And then she has progressive disease, but she attends the hospital for opinion, and but she is put on treatment. And then again, when she comes back on 2025, she has breathlessness and fatigue and unable to go on to trial with new drug. So we need to keep this lady in mind when we are, and what can we do for her is what we are going to see in the next few slides. So do we need to integrate, and why do we need to integrate? And this is some of the things that I've already told you, that she is undergoing disease management, so that is going with that. She has some physical symptoms. She might be having psychological, social problems, spiritual suffering, and you can see that she is sort of, even if we saw her in 2024, she was not in a perfect condition. So we have to make some kind of anticipatory planning, advanced care planning, and this is why, and this is for, and not just for the patient, but also for family. And this is why we need to integrate. And one is the concept that palliative care comes right at the end. You can see that palliative care goes hand in hand with curative intent treatment, and we manage the exacerbations and remission of diseases. More towards the end, maybe palliative care has more of a component. And what is very important is that palliative care does not stop at when the person has died, but we provide bereavement for the family. And we know that palliative care should come in early, but this is the landmark trial that came in 2010, which showed and proved and broke the glass ceiling that if you introduce palliative care early in advanced lung cancer, and it was 2010 when there really were no treatments. Now we gone to the other end of the spectrum and to so many treatments, but palliative care is still pertinent. And this proved that, that with early integration, there's a better quality of life significantly, there's less depression significantly, and there is less aggressive end-of-life care. And this one proved that there was longer survival. So this broke the glass ceiling, and that this is the one which has made it into ASCO guidelines, NCCN guidelines, ESMO guidelines, and rigorous study. So more studies then happened later, and that's a 2017 Cochrane review, which included 7 trials with 1,600 odd participants with a bit of low risk of bias. But what is important, we are talking about quality of life. So all trials, this in the Cochrane review, you saw that there's improvement in quality of life. There is definitely reduction in symptom burden, although at 2017, not very sure about effect on mortality and depression. But what is very important from this paper is that the type of model did not make any difference. So if I'm sitting in a primary care clinic, or if I'm sitting in a specialist care clinic, or if I'm providing palliative care in home only, it did not make any difference. And so what is the evidence from LMIC context? So there are a few studies which have been done for feasibility, and one study in Ethiopia initially for feasibility, and then later on transferred into a proper pragmatic randomized trial. And another study that we have done here, which it's important to know that the study for Ethiopia, whether it was feasible, attrition was high, but it still showed improvements in patient-reported outcomes. So that means it can be, and there were some cost benefits also. In our study, feasibility was not met because we had a pre-specified criteria, which may not have been the correct one, but definitely there was pain and anxiety which improved, and quality of life scores improved. And so this led to more sort of trials. So then in Asian countries, you can see, of course, the developed ones like Japan, Korea, Singapore. There are different models of integration, and that's quite in implementation. The early integrated home-based palliative care, important one, the one done in Ethiopia, was delivered by nurses, and it was at home. There have been a few studies in India in breast cancer, in head and neck cancer, and in different parts of the country, at other places, people have been trying to do quality improvement initiatives in getting palliative care integrated early in the patient's illness trajectory. There is one phase 3 randomized trial that we did, which did not really have much of difference between standard care and APC, but this is just one of them. But there are reasons for why they didn't show that amount of significance. And the recent systematic review has shown that there's improved patient outcomes, reduced hospital stays, etc. And important to see that how in LMICs, we have to think about LMICs. So what are the models of delivery? All of us are not sitting in specialist palliative care clinics in tertiary care centers like us. So important to us that there were nurse-led studies, There were generalist-led studies, volunteer-led programs, home-based palliative care, early integration of palliative care at home, and task shifting and task sharing, because these are the things we need to know when we have to build a model for the patient that we have been seeing, and that's just an example. And if you see this map, if you see Asia and Africa, most of it we come into emerging, progressing, and established. There's one or two which are advanced levels, and you can see that most of the deaths will occur in our countries, and there is so little access to palliative care. So why is that? We know from high-income countries, we know that there is evidence. From LMIC context, we know that there is evidence. So for LMIC context, what are the barriers? So it seems that there's a large variation in integration of palliative care across the LMICs, and a lot of it is of lack of policy support, although Africa is doing a great job, and the Middle East also there is a great thing about policy. So lack of policy support, unmet educational needs, we do not have the trained staff, and constraints in accessing palliative care because of geographical issues and other issues because of schemes, etc. And we must realize that, the referral practices differ, and there's also a lot of fragile financing. We talk about universal health care, but for palliative care, some of us are always dependent on philanthropy, NGO support, voluntary sector support. So you're always dependent on someone, and there has to be financing. And resources are a problem not just with us, but it is also in the high-income developed nations. So they said yes, in all the guidelines, it is early integration. Fine, people started referring to palliative care when realized that you don't have so much of resources in staffing in palliative care. So they also have been trying to modify different models. So we've come to sort of timely palliative care that also helps. And this is a recent trial on step palliative care, that the early standard palliative care is that the patient had to meet the physician regularly every month. But what if we meet only when somebody refers or the situation worsens? So it showed that it was not inferior to the standard care. So it was not a superiority. We wanted to show that 4 visits is as equal to 6 visits, is the author showed. And what about the in-person visit? Do we always have to go in person, or can we do telehealth? And this is another study that we have that the Tamil et al. Group has done that, and that also you can see that it is equivalent. So when we are thinking of this lady, what, when, and how should we integrate? So I know we don't have much time, but what we can say is that definitely an early integration. So when she came to us for the first time in 2023, that is when I would integrate, rather than waiting till 2025 when so much of progressive disease has already happened, because I had to plan for the progressive disease and managing the symptoms from here. So if I do that there, then that is when I realized that the importance of quality of life and symptom burden. And basically for her, I need to think about where she is. So palliative care has to move to wherever the patient is. So maybe in the community, maybe in the service, maybe in the inpatient, or maybe at home. So we need to think about what works for whom and when and which setting. And for that, we need to think that it is not just equal to end-of-life care or hospice care. It is not about giving up. It is not about when treatment is not working and only morphine is not the overall thing. So this sort of what we want to do, what do we want? We have to have something which is timely, something which is value based, something which needs staff skills, that we need care coordination within teams, and we need to have leadership at all levels. So I think this is the formula that we need to keep in mind, because what works for me may not work for you or you or you. So we need to think. But the basic ingredients, which I call are my 6 P's, but it's the patient and parivar. Parivar is the word we use for family in the center. We have a problem. We need professionals. Those professionals need to have a passion to make a difference, and it has to be a pliable model. Just because this works for me doesn't mean it works for you. We have to find the main components and see how best it works for patient, caregiver, and the providers and the settings that we are in. So for LMICs, what they say is that we should really have a public health perspective and a community perspective, and maybe that would work better. And I leave you with this, that of course the world is full of suffering. Do we know it so well, especially this year? But it is also full of the overcoming of it. And this is where palliative care comes in. Thank you for your attention. Thank you.
This is a pre-recorded video by Dr. Ajay Apuri.
Good day, everybody, and welcome to the Tata Memorial Center. I shall be speaking to you today on limb salvage in extremity sarcomas, the challenges we face and the options that we have. I'm an orthopedic surgeon, and that is nothing but medical terminology for a glorified carpenter. These are the tools of my trade, and most normal orthopedic surgeons would deal with issues like this: arthritis, fractures, back pain, wrist, ligament and joint injuries, etc. But unfortunately or fortunately, because of working in a large cancer center, this is what I deal with: bone cancer. Now, bone cancers or sarcomas are very, very rare, and such cases are best referred to specialist centers. Even though I say that they are rare, because the Tata Memorial Center is a tertiary referral center, we see quite a large number of these cases annually. We see close to 650 primary soft tissue extremity sarcomas and about 550 primary bone tumors. We do close to between 450 to 500 major bone tumor surgeries every year. When a patient is diagnosed with bone cancer, they and their families go through a host of negative feelings, which include despair, fear, anger, and this feeling about why me and what have I done. Most bone tumors also come with an image of an amputation and a lifelong handicap. Yes, amputation may occasionally be needed, and it is the most merciful of surgeries when it is the only resort, but the meanest of surgeries when better alternatives are available. And today we have a lot of alternatives. Limb salvage is the norm in bone sarcomas and not the exception. And between 80 and 85% of the patients that present to the Tata Memorial Center actually have limb salvage. Now, when you talk of limb salvage, you must realize that we are trying to balance the oncologic aspect versus the functional aspect. We want to remove as much of tissue as possible to ensure adequate margins and lessen the risk of the tumor coming back. but we also want to retain as much of tissue as possible so that the salvaged limb has a function as close to a normal limb as possible. And you will realize that these are two aims that pull in opposing directions. And striking the right balance between oncology and function is the key to providing good care to these patients. Limb salvage consists of tumor resection followed by skeletal reconstruction. But a question we occasionally ask, is reconstruction always necessary in every tumor? While it may be required in the large majority of tumors, there are some areas that we do not need to reconstruct. This is an osteosarcoma of the metacarpal or the finger, which has responded very well to chemotherapy and is treated by a ray amputation. And you can see, even though the child is missing a digit, the function is quite good. Similarly here, in a case of an osteosarcoma of the scapula, we have done a scapulectomy or complete excision of the scapula, yet this boy retains a fairly decent shoulder function. But a large majority of bone tumors occur close to the joint, and therefore we need to resect the diseased bone along with the adjoining joint for oncological safety, and that alone will ensure a safe margin as far as the resection is concerned. Now, the most attractive proposition for reconstructing these large gaps is something that not only spans the gap but allows joint movement, and that is a large prosthesis, which is therefore called a megaprosthesis. In cancer surgery, not only do you need to recreate the articular surface, you also need to replace a large segment of bone. And this video will illustrate what I mean. This is a tumor at the distal end of the thigh bone close to the knee that requires resection. It is then removed and replaced with a megaprosthesis. Interestingly, this video was made by one of our patients who had limb salvage, was a survivor, and went on to become an animation expert. That's how the prosthesis is assembled on table. It can be modular and therefore can fit each and every patient and a different resection. And that is the sort of function that we expect after replacement with a prosthesis. When we started doing this at Tata Memorial Hospital close to 25 years ago, we didn't have good, indigenous, inexpensive prosthesis. The prostheses available were imported expensive ones, and therefore we did face our own challenges. But we went ahead and developed an indigenous prosthesis that we have used now for the last 25 years, and it has given us excellent function. We were also given the Golden Peacock Health Innovation Award for this, and it is a prosthesis that costs less than $1,000, which is about 1/10 the cost of an imported prosthesis. We went through our own design and development, including cadaveric models, etc., to have a prosthesis that gives excellent function. We've published our data in many international journals, and not only small segments of bone, but in fact, occasionally even entire bones have been replaced with this prosthesis. This is a case in point, the total thigh bone or the femur being replaced by a total femur prosthesis. We have very happily shared this development and prosthesis with many countries in Asia and Africa to enable them to have their limb salvage programs. And more than 12,000 of these have been implanted in the various countries marked on this map. But having sold you the concept of a prosthesis, is a prosthesis always functional? There are rare occasions when putting in a prosthesis does not actually serve the purpose. In this case, a large tumor in the upper arm, which involves the muscles and the nerves, and means that we need to resect the muscle and the nerves to get a good margin. Putting in a prosthesis actually only serves as an expensive spacer for good elbow and hand function. It does not give any shoulder function. And in cases like this, we have realized that replacing a prosthesis with an inexpensive, simple metallic tube called as a Kunsher nail, which is less than $25 US, gives us the same function that a prosthesis would. Our published results show an excellent implant survival at 5 years with this innovative low-cost reconstruction. In children, we face unique problems. The bone is growing, the metallic prosthesis does not grow, and therefore when the child becomes an adult, the two limbs are not going to have the same length. The one in which we have put a prosthesis is going to be shorter than the other. Here you can see a tumor at the distal end of the knee, which is resected, replaced by a prosthesis as I showed you. That is how it looks after surgery. But when the child grows, the normal leg grows, the prosthesis cannot grow. And therefore, at skeletal maturity, you have limb length inequality. For such cases, we have an expandable prosthesis where you can actually make the child either undergo a small procedure to increase the length of the prosthesis, or with the new technology available now, have a magnet inbuilt into the prosthesis. All you need to do is stick the patient's leg in a magnetic coil like a mini MRI, and the prosthesis can actually expand. This is a case in point. You can see the prosthesis when it is put on the left, and you can see after expansion how it is on the right, and we can continue to expand it so that the operated limb can match the normal growth in the normal limb. But apart from all this heavy metal, we also use a lot of biological options. And one of the options is the fibula bone in the leg. That is an extra bone that God seems to have provided us with purely for the orthopedic surgeon to use. And here you can see a tumor in the humerus, which was resected and replaced with a vascularized fibula with the help of our plastic surgeons. It incorporates like any normal bone does, and you can see the child's function. But in places where we are challenged to have a plastic surgeon to help us with microvascular anastomosis, we've innovated even further. For example, in the leg, where we again have the fibula adjoining the tibia, if there is disease in the tibia, we remove it, we do an osteotomy of the fibula and just move the fibula into this gap without the help of a plastic surgeon. It moves along with the muscles attached to it, and therefore it is vascular and gives us an excellent result, as can be seen on the X-ray on the right. But in a country like ours, and even many of the African countries, which lack an organized organ donation program, getting a bone from a deceased donor so that you can have allografts in a tissue bank to replace resected bone can be very challenging. And in these cases, we have used another innovative option, which is sterilizing the tumor bone and re-implanting it back during the same surgery. Here you can see the tibia is resected. It is put in a sterile bin, taken to our radiotherapy chamber in the basement, radiated to 50 gray, and then brought back and repositioned back in place where it originally was, but this time free of tumor. And you can see the boy's function. This is a few years after surgery. On the right is many, many years after surgery, where he has now graduated to actually become a medical doctor. Our published results show that these radiated bones have actually done very well. Our 5-year graft survival is almost 85%. And just like the radiated bone, we can also use cold freezing to kill tumor cells. This was a process that was actually started in Japan and has been taken over by a lot of the world, where again the resected bone, instead of being subject to radiation, is actually put in liquid nitrogen and is sterilized and reimplanted back. This is the case in point where this can be done in the operating room itself, the resection done, the bone dipped in liquid nitrogen, held there for 20 minutes, freezing all the tumor cells, killing them. Then we thaw it and position it back, and you can see how well this bone has incorporated. So I have shown you a host of choices that are possible when you want to do a reconstruction. Which is going to be the correct choice for each particular patient requires a lot of thought, discussion, and dialogue with the doctor, the patient, and the family. It depends on the amount of bone resected, the status of the residual tissue, the age and health of the patient, what the patient's lifestyle and expectations are, what is the infrastructure available to the surgeon and the hospital that he or she works in, and what is the surgeon's comfort zone. All these need to be balanced together before you make the choice in joint discussion with the patient. So it's important that you need to study principles, not methods. A mind that understands the principles will devise its own methods. And importantly, in oncology, we all need to work together. It is a team effort. Everybody must understand their role and work together. And only then we can discover new oceans when we have the courage to lose sight of the shore. Thank you very much.
So thank you very much. We had a great session and we ended up with the best.
Thank you, sir. Thank you so much. Thank you for organizing all the speakers from the esteemed University of Tata Memorial Hospital and giving us your valuable time and knowledge, sharing thoughtful, insightful presentations to us all around the world. And Merck Foundation alumni would have definitely benefited from all the presentations, and they will be having a lot of question and answers and videos. The presentation recordings will be asked from them. So we'll be getting back to you for that and get the approval from your end, and we'll do the needful, sir. Thank you.